Welcome to the 15th edition of Kalpavriksha. Kalpavriksha means wish-fulfilling divine tree. We started this national level PG update program way back in 2007. This is our beloved chairman and managing director, Dr. Amar Agarwal's brainchild. This year, we are having it online. This has been happening for the past 2 Saturdays, consecutive Saturdays, we've been having Kalpavriksha. And today is the concluding day of Kalpa 2022. Our speakers are all handpicked and they are the experts in their field. Welcome one and all to the third consecutive Saturday of Kalpa 2022. Today, we are going to be covering up orbit, oculoplasty, SQUINT and UVEA. After each session, if you have any doubts, you can put it up in the chat box. We'll be in a position to answer your questions. The first speaker is going to be Dr. Preeti Uday. I take the privilege of introducing Dr. Preeti Uday to all of you. She underwent fellowship training in orbit and oculoplasty at Shankar Nethralaya. After completing her MS, DNB and FRCS, she is well-respected academician and oculoplastic surgeon both in India and abroad. She has trained several oculoplasty fellows and postgraduates. She heads oculoplastics for the Agarwal Group of Eye Hospitals. She is also the director of BRR Eye Hospital. She is also a global examiner for FRCS. She has special interest in facial aesthetics and orbital surgeries, especially in trauma and navigation guided surgery. We welcome you, Dr. Preeti. The first topic is going to be examination of a case of an orbit.
Thank you very much for this kind invitation, and it's nice to spend this evening with all of you. I'll just take you through a very basic topic of examination of a case of orbit. I hope I'm audible there. Yeah?
Yes.
Yes.
Yeah. So when we see the case of orbit in the exam, we must know the terminology first. You know, what is proptosis, what is exorbitism, what is exophthalmos and hypertelorism. These four are very confusing terms, and I will tell you what exactly the examiner wants. It's usually proptosis is forward protrusion of the eyeball. Exorbitism is whenever there is a protrusion because of shallow orbit. That is, the bony volume is reduced, but your orbital content volume is normal. Okay. Exophthalmos is when your orbital content volume is increased, like in thyroid cases, but your bony orbital volume is okay. Okay. And hypertelorism is when there is increased distance between the orbits. That is, your interpupillary distance has increased. Okay. So I hope that clarifies all these terminologies. Now, whenever you go through a case of orbit, you have to think in terms of four main pathologies in the orbit, which you can remember with the mnemonic vein. Okay. So V is vascular abnormalities, E is endocrine, I is inflammatory and infectious diseases, and N is neoplastic. Okay. So when you see a patient walking into your clinic, you first rule out a pseudoproptosis. Okay. So you look at the patient if there is any facial asymmetry. You see if the patient is wearing high-powered glasses. So you know if one side the glass is thicker, it is a unilateral myopia. You also rule out other eye enophthalmos. Look at the color of the sclera, whether it is bluish to rule out of the ophthalmos. Ipsilateral lid retraction. So look at the eyelid position. The upper eyelid should rest about 2 millimeters below the limbus. If you find that the lid is retracted, you think more in favor of a lid pathology, lid retraction. So that will give you a thyroid as one of your etiologies. And also contralateral enophthalmos. So pseudoproptosis is something that you must rule out first. Like in this picture that you can see, it's a very obvious cryptophthalmos because of, Crouzon's disease because of shallow orbits. Because it's bilaterally symmetrical, the orbit is shallow, the eyeball is proptosed out. Of course, age is important because certain pathologies are seen more commonly in certain age groups. Like in infants, you will see capillary hemangiomas and encephaloceles more commonly. You will see lymphangiomas more commonly in childhood. So if you see a swelling like this, which crosses the eye unit into over the nose to the forehead, then you think more of a lymphangioma. Then dermoid cysts like this and orbital cellulitis you see more commonly in children. In adults like middle age, you will see more commonly thyroid, pseudotumors, lymphomas, meningiomas, and cavernous hemangiomas. And in elderly people like this with temporal area fullness, you will think of metastasis. So age gives you a clue as to what the pathology can be. Okay. Then the onset, of course, when there is a very acute onset, you will think of emphysema, hemorrhage, fulminant infection, or very rapidly growing malignant tumors. Or days or weeks would be inflammatory, and months or years would be low-grade inflammation like IOIDs or pleomorphic adenomas or dermoid cysts. And whenever the proptosis is intermittent, you can have hemorrhages in lymphangiomas, or you can have orbital varices, which changes with Valsalva maneuver. Like if the patient is lying prone, you will see it. When he's training, you will get it. So it will be intermittent. And of course, diurnal variation is very typical of thyroid. Thyroid patients have more problems in the mornings. And pain is a very specific symptom of inflammation, infection, any acute thing like an orbital hemorrhage or malignant tumor. And of course, other symptoms, you need to ask the patient for double vision, vision loss. Now, vision loss can be because of external compression on the optic nerve, because of increase in the orbital volume, or it can be optic nerve pathology like optic nerve gliomas, optic nerve sheath meningiomas. And of course, history of fever is important in acute infections, and other symptoms which will tell you, which will lead you to the pathology in the orbit. Now, coming to inspection, first look at the patient without touching the patient. When you see the patient, look at the eyelid first. Eyelid gives you a lot of clues. Like if there is a lid retraction, it is quite commonly thyroid eye disease. And you will see any swelling, inflammation. Look at the facial asymmetry. If you see ecchymosis like this along with the proptosis, it can be a leukemia or a neuroblastoma. And of course, eczematous lesions like mycosis, you will be able to pick up just by inspection. Also, just don't look at the eye, look around the eye also in the periorbital area. Like in this patient, you can see fullness in the temporal fossa. This can be because of metastasis, because of Ewing sarcoma, it can be because of sphenoid ring meningioma. So there are 3-4 conditions which give this kind of a typical appearance. And of course, when you have this kind of an eyelid, which is very obviously a neurofibroma. Now, globe displacement, then you come to the eyeball and you see which side the eyeball is displaced. So if it is axial displacement, you know that the lesion lies in intraconal, okay? That is behind the eyeball in the intraconal space. And if it is non-axial, depending on which side the globe is displaced, you think of the pathology. So if it is displaced inferomedial, then you know there is something superolaterally. And there we just have the lacrimal gland. So most commonly it is lacrimal gland pathology, or you can have dermoid cysts. Now, if the globe is displaced inferolateral, then of course superomedial is your pathology, which is most commonly ethmoid mucosal or osteomas. Superior displacement on the globe we see in maxillary sinus tumors, like in this elderly lady, she had a maxillary sinus carcinoma. And inferior displacement will be, of course, because of superior lesions like this. In this boy had an abscess in the superior orbit. Now, how do you confirm if the patient has proptosis? You do a Nabziger's maneuver, that is, you stand on the head end of the patient, ask the patient to look from down to straight. You will see which cornea comes up first. That side is proptosed. Okay. So Nabziger's maneuver or worm's eye view will give you a better clue as to whether there is proptosis or not. Now, exophthalmometry readings, you need to know what kind of reading is abnormal. That depends on the racial variations. So for our Indian population, we keep that kind of limit as 21 millimeter. So any displacement of the eyeball more than 21 millimeter is considered to be proptosis. But most commonly in the clinics, what we use is difference by more than 2 millimeter between the two eyes. And in ophthalmos is less than 12 or 10 to 12 millimeter of reading on hurtles. Now, comparative exophthalmometry is when the results are compared from time to time during the study. And relative is, as I said, difference in 2 millimeter. Now, there are various methods of measurement. What you need to know is the hurtles exophthalmometry in the exam. You can just measure axial forward displacement of the globe by a simple ruler or a Lewis exophthalmometer. Now, this is the Lewis ruler. You just place it at the lateral orbital rim and you can see the displacement of the cornea anteriorly. And this is the hurtles exophthalmometer, where the protrusion of the apex of the cornea in front of the outer orbital margin is measured when the eye looks straight ahead. Now, for this, you must have a normal lateral orbital rim. So if you have a proptosis, but this lateral orbital rim is damaged because of trauma or something, you will not get a correct reading on hotels. You also have these kind of rulers which are also attached to slit lamp, where you can measure the upward and the horizontal as well as the vertical displacement of the eyeball. This is a very old picture from Duke Elder. Sometimes some of the examiners like to ask you this. So this is a Watson's topometer, where you can measure the axial, the horizontal and the vertical displacement. And this also some examiners like to ask you what is piezometry. So basically, this is how much resistance the orbit gives to any fixed compression on the eyeball. And you must look for change in Valsalva. So ask the patient to bend forward and strain and see if the proptosis increases, which is very typical of a varices. And then you go on to palpation. Now, when you palpate, you first look for warmth and tenderness, because if you go on and do finger insinuation or other things, that can itself increase the temperature. And if you do that first, definitely examiner knows that you're not looking for the warmth and tenderness. So look for warmth and tenderness first. Look for a thrill, and then you do the finger insinuation or palpate the orbital bone. And then look for lag of thalamus. Ask the patient to close the eye and look for lag of thalamus. And then you do a resistance to retropulsion. That is, you just press over the closed eyelid and see how much resistance you get. So a compressible lesion like, cavernous hemangioma, any of the hemangiomas are more compressible, whereas a solid tumor will give you more resistance to retropulsion. And vascular pulsations, you must look for thrill may be present like in CCFs. And cerebral pulsations without a thrill you can have because of defects in the bony orbit, like you see in meningoceles, encephaloceles, neurofibromas, or traumatic hiatus in the roof. Ocular movements are very important, and of course pupil. And you must palpate for regional lymph nodes like preauricular, submandibular. You must know the lymphatic drainage of the orbit, because when you palpate, they will ask you. So lymphatic drainage you must know. Usually of the eyelids, the orbit has no lymphatics, but the eyelid drainage you must know. And of course, palpate for the thyroid gland. So the commonest case given in exam would be a thyroid. Then auscultation for bruit, this we rarely do, but you must mention that to the examiner to complete the examination. And of course, visual acuity is important, color vision is important. And then you go on to slit lamp examination, which gives you some clues as to the pathology. Like if you see a salmon colored patch in the conjunctiva, you know it's a lymphoma. If you see corkscrew vessels, you know it is a keratoconus fistula. If the cornea is exposed or not, you will know, you can tell the severity of the proptosis from that. And if you see Lish nodules on the iris, you know that it is a neurofibroma. And then you check the intraocular pressure in the primary position. If you suspect a thyroid, then you also check the intraocular pressure in upgaze. And any difference between the two by more than 4 millimeters is considered to be positive. Then posterior segment, there are some signs which again tell you how severe the proptosis is. If you have choroidal folds, if you have optociliary shunts, you know it is a meningioma. If you have venous engorgement or a disc pallor, then you know that optic nerve is compressed. Other important examination would be ENT examination, rule out any sinus pathology, thyroid, and also rule out systemic signs like neurocutaneous markers in neurofibroma. Thank you very much for your kind attention. Any questions I can take right away.
Thank you so much, Dr. Preeti. You made it look really simple, and it's a very, very important exam case. So, and you kind of precisely condensed everything and put it together. Thank you so much for a wonderful session. And if anybody has any questions, please put it in the chat box. We'll move on to the next speaker now.
So our next topic for the day would be investigations and differential diagnosis of UVEA. And for that, we have our very own Dr. Divya Ashok Kumar. She is a senior consultant of UVEA Oculoplasty and Oncology Services at Dr. Agarwal's Eye Hospital. And she is from the prestigious All India Institute of Medical Sciences, New Delhi. And she has quite a number of peer review publications to her credit, and a lot of contributions for book chapters in books, and multiple innovations to her credit, and has won several awards in national and international conferences. I'd like to invite Divya ma'am for her talk now. Thank you, ma'am.
Can you hear me? Thank you, Preeti.
Yes, ma'am, we can hear you, and we can see your slides as well.
Yes, good evening, everyone. We have a topic on investigations and differentials in UVEA. As you all know, the SU1 classification is usually we do in clinics, and anatomically we divide uveitis into anterior, intermediate, posterior, and pan-uveitis. Anterior is anterior segment, like you have iris and iridocyclitis and anterior cyclitis. Intermediate is the pars planitis. Posterior is retinitis, choroiditis, chorioretinitis, and retinochoroiditis. Pan-uveitis, involvement of the all the layers. You have to differentiate in slit lamp ciliary and conjunctival congestion. That is the first evaluation you do as such in the OPD, where you see the episcleral veins and the ciliary vessels becoming more prominent, which is seen as violet color, and it is intense at the limbus, which do not move with conjunctiva and flows from limbus. As compared to the conjunctival hyperemia, which is more bright red and intense near the fornix and moves with the conjunctiva. In SU1 classification, all of you know, which you should be remembering about the classification from 0 to 4 of the flare and cells grading. In clinical evaluation, you have to look for iris, corneal, pupil changes. As you can see here, active and chronic stages. In active stage, you will see cells flare. You see the Tyndall effect here, where you can see the cells in the anterior chamber with magnification and illumination, good illumination in dark room. You can actually see the WBCs in the anterior chamber. You grade it. And you also see the cornea for endothelial KPs, which could be a stellate KP or a large granulomatous KPs, can be mutton fat type. You also look for the nodules in the pupil. Sometimes you can see fibrin membranes like this in the anterior chamber covering a pupil also. Endothelial pigments and mutton fat KPs, greasy appearance tells you about the granulomatous nature of the uveitis. You should always look for the sequelae when you see in the slit lamp for cataracts, posterior synechiae. Especially the complicated cataracts will have polychromatic rupture and posterior subcapsular opacity. And sometimes you can have angle closure due to the peripheral anterior synechiae. So these are the complications usually we get the posterior segment macular edema, optic nerve involvement in glaucoma, and angle abnormalities, and commonly is cataract. Why should one investigate in uveitis? First, to determine the etiology, to identify the complications, and to follow up these patients and prognosis also. So when you divide this investigation as such, you divide as ophthalmic and systemic. Even in ophthalmology, you divide it as non-invasive or non-contact. Sometimes invasive and contact is also required. So non-invasive, predominantly we do OCT, either posterior segment or anterior segment fundus photography. In contact or non-invasive methods would be in fundus angiography and UBM. At times we do diagnostic tap also. Systemically, we evaluate most of the cases. We do blood urine routines, serology for viral markers, antibody assays, enzyme assays, genomic wherever required. And sometimes we have to do a lymph node. These are all specific patients. We need a lymph node biopsy, sputum microscopy, skin test, which is commonly done, Manto test, HLA typing, and radiological evaluation. So few investigations we commonly do in a routine practice for UVL patients. We'll see here you can see the posterior synechiae being formed. There is iris bombi, there is peripheral anterior closure. So this patient will present with a secondary angle closure glaucoma with uveitis. So in these patients, when you see clinically and you can evaluate them, need to take necessary measures to treat it and follow them with the investigation. You see in posterior segment macular edema with cystoid spaces and follow up the patients with posterior segment OCT. Sometimes you may not see the cornea, you may not see the anterior chamber because of the haze of the cornea. In that case, you can do an ASOCT and you can see the infiltrates inside the anterior chamber clinic in the imaging system. Fundus photography is very useful in prognosis and also follow-up of these patients, where you can actually show to the patients. Specific conditions where there is other system involvement like ankylosing spondylitis, psoriasis, which can predominantly have joint and skin involvement, you do specific tests, especially HLA B27, where you can see few conditions like ankylosis, there is specific HLA B27 uveitis, reactive arthritis. All these conditions can have positive HLA B27. So we don't do that routinely for all patients. Wherever needed, in specific cases where you suspect an young patient with joint pain, backache involvement, then you do it. These patients, they will have this backache because of the this disc involvement, where the joints get fused, inflammation, recurrent inflammation going in for the bamboo spine, appearing like a bamboo. As you can see here, the spine also becomes like that. So the spine X-ray may be needed and you get a referral from the concerned specialist. Reactive arthritis with skin involvement, Or in psoriasis, you go for the evaluation of the skin and do an X-ray, the hands, and identify the ankylosis or arthritis. Usually this interphalangeal joints or intercarpophalangeal joints are involved. Inflammatory bowel disease symptoms are more important. You ask the patient for recurrent diarrhea and abdominal cramps, and sometimes you might require endoscopy also. Coming to differentials, depending upon the age and their comorbidity, we differentiate the other conditions of uveitis. Commonly in children and under 16 years, you will see this JRA related uveitis. Could be with and without ANA positivity. They can have synechiae with band-shaped keratopathy. They can have coexisting cataract also. In a few heterochromic cyclitis, clinical evaluation is more important because it's basically a clinical disease where you see this stellate fine capes, absence of posterior synechiae is pathognomonic. You will see heterochromia between the iris. These patients can have raised IOP, sometimes atypical presentations of retrolental cells, vitreous haze also. Amsler's sign, which is typical seen in the anterior chamber where there is a hemorrhage on AC paracentesis. Cataract can be seen, which actually is very good prognosis in these patients. This is a patient with a total cataract with a stellate fine capes in the endothelium. Lens-induced uveitis, it is again a known factor where you can have a patient's lens protein comes out because of trauma or after surgery, or the patient has an UGH syndrome where there is uveitis, glaucoma, ephema because of the lens getting touched towards the iris. As you can see here, this iris is touching the optic of the lens. So there is chafing of the iris, inducing pigments release. This in turn causes inflammation in this patient. This patient has a bilateral UGH. Can also sometimes see ephema like this with tilted eye oval touching the iris and inducing microscopic leak or hemorrhage. You might have to do UBM in some cases where you suspect a ciliary body mass or ciliary body cyst. And this patient, as you can see inferiorly, there is a mass lesion where UBM will show the cystic nature, and this is a post-YAG of the same lesion. It is getting recovered. So some patients, wherever needed, you an OCT or UBM, you decide accordingly. Sarcoidosis is another common condition where we might require HRCT for the patient. Chest X-ray, mildly it can show, but sometimes you can miss hilar lymphadenopathy. Predominantly nowadays we do HRCT. So here you can see the candle wax dripping with the granulomas in the conjunctiva and non-caseating granuloma in the biopsy. Hematologically, most of the patients routine are done for the blood hemogram, ESR, CRP. Sometimes we go for other tests, like wherever indicated when you are suspecting a granulomatous inflammation, serum ACE, globulin, lysosome, LFT, RFT is needed. Immunologically, when you think of any viral etiology, you go for the antibody titers like IgG, IgM, HSV, HZV, HIV, and CMV. IgG, IgM toxoplasma in parasitic inflammations also. See, this is a patient of viral keratouveitis, corneal edema, non-resolving inflammation is there where you want to look for the endothelial decompensation. You add additional investigation, so you can do a confocal microscopy or a corneal endothelial density analysis also. Radiologically, as I told you, HRCT is required in sarcoidosis. As you can see this lymph nodes lymphadenopathy, and in tuberculosis, you can see the fibrotic lungs here. Sometimes in intermediate uveitis chronic cases, you will for ruling out a multiple sclerosis or in a masquerade, you will require MRI brain. This is a very important test, the Mantoux test. Many of them, they missed the interpretation. So Mantoux is routinely done with the intradermal injection of the PPD. More than 15 is considered to be positive in a normal patient who is not in a high-risk group. If a patient is very immunocompromised, even at 5 millimeter, we consider it is a positive. So around 10 millimeter normal patients get taken it as a borderline unless otherwise he is an IV abuser or a patient working with the high-risk persons. Renal disease can also be associated with uveitis. That's why we ask the patient for any renal associated pedal edema or treatment for any renal complication, because glomerulonephritis and interstitial nephritis, they are also autoimmune induced. There are a lot of diseases of renal parameters affected in these conditions like SLE, sarcoid, rheumatoid, vaginous. So patients who have these associated syndromes, they have to get evaluated the eyes for uveitis. Masquerade is another group which always comes as the differentials in uveitis. Even malignant and non-malignant differentiate lymphoma, primary intraocular lymphoma, uveal melanoma, paranoidoplastic syndromes can present. Non-malignancy like intraocular foreign body, rheumatogenic RD with pigment dispersion chronically, myopic degeneration, ocular ischemic syndrome, infections, especially endophthalmitis, post-vaccination, drug-induced, all this can mimic like an uveitis. This is a patient of the intraocular lymphoma. These patients might require a biopsy, actually, cytology to confirm it. It's a patient who has this multiple like, shiny things in the anterior chamber. This is actually cholesterol crystals. Was referred as a uveitis. This patient had a Coats disease. So always look entirely in the patient, look for other findings, and you come to a conclusion whether to investigate or not. VKH is another common condition. It's a pan-uveitis. We can have anterior to posterior presentation. Here you can see the choroiditis with serous detachment. So this patient required an FFA, where you can see leaks and you can see pinpoint hemorrhages typical of VKH. And you might require OCT to look for this fibrinoid changes. The septations are typical oculated septations seen in the VKH. Unlike your exudative RD, this is in a patient with exudative RD where it's clear serous fluid without any locculations. You can see the elevation of the retina. You can also use OCT angio in patients where you're suspecting a CNVM. This is a patient with VKH with secondary inflammatory CNVM. You can see the capillary and vascular plexus in the macular region. And post-treatment fundus photographies are very much useful in all your patients when you treat them and follow up them for prognosis. You can see the ATT therapy before and after the therapy improvement. So wide field angle, if you're seeing any peripheral lesions in a small, because most of them will have myotic or pupil which are very small because of posterior synechiae. So if you want to get a wide field view, like in this camera, you can see the choroiditis in the periphery. And another topic is ocular toxoplasma, which is the commonly seen, and OCT can be useful in such patients to look for this retinochoroiditis, where the disorganized retinal structures are seen in the inner retina. They can be associated with the choroidal thickening and subretinal fluid. And what are the reasons for ultrasound? If suppose a patient has got hazy media, when you're not able to see through and through the retina, in such cases, you require an ultrasound, especially when the patient has dense vitritis. As you can see, the vitreous cells here, and there is a moderate echoes, and there is a membrane here. If you want to look the membrane, the other axis, you can see here it is a high spike showing that it is a retinal detachment. Mostly this patient might be having an exudative RD. You can also use in patients which pupil is not dilating. See, this patient is having a small pupil, posterior synechiae not able to dilate. And in the B scan, you can see the elevation. There is here fluid accumulation. There is thickening of the choroidoretinal complex. This patient actually is a VKH because other eye is atrophy. This is the unilateral VKH presentation. Systemic monitoring also required in patients who are on treatment. That's why we investigate them, especially patient on immunomodulators, complete hemogram, liver functions. And whenever needed, you do a liver urine analysis and stop the drug when there is cell counts which is less than 3,000. Invasive investigations we do like AC tap or vitreous tap whenever there is dilemma and diagnosis, or refractory to treatment, like you are on chronic treatment patient again and again comes, there is difficulty, or you are suspecting some masquerade, you can do the investigations. Kolmar-Whitmer coefficient is usually done for to rule out the antibody titers and to find out whether is there active intraocular antibody protection, and wherever required, we do that investigation. So when not to investigate is more important. Whenever a patient comes with first episode of anterior uveitis and it is not vision threatening, do not investigate. And a patient with a known systemic disease like an HLA related or joint problems, sarcoid or tuberculosis, then you need not investigate. Already any clinical sign you are seeing, suppose a patient is having a tilted or touching IOL, suspecting a UGH or a phacolytic, or a trauma history is there, in those patients you will not investigate. The evaluation is not complete unless until you get an opinion from the concerned review from the psoriatic or from the dermatologist, or a rheumatoid arthritis from the rheumatologist, and a physician review for any lung infections. I think that covers most of the investigations. Thank you.
Thank you, ma'am, for that wonderful talk. And I think there were some beautiful pictures there, well explained. And the topic itself was very concise. Like, they just have to pick up your presentation and just study that thing. That much itself is enough for the exam. Thank you so much, Divya, ma'am. So I'd like to call upon our next speaker.
Thank you.
We have a very young and dynamic Dr. Karpagam. So she is our senior consultant with Agarwal's. And she's a cataract surgeon and a uveitis specialist with us. She has completed her MS from Arvind Eye Hospital, followed by a fellowship in uveitis from the prestigious Shankar Nethralaya. She also happens to be the dean of Dr. Agarwal's Institute of Optometry. and she's actively involved in teaching postgraduate students. And I'd like to invite Dr. Karpagam for her talk.
Yeah, thank you, Dr. Preeti, for this lovely words. Can you enable screen sharing for me? Are you able
Ravi?
to see my screen?
Already enabled, madam. Already enabled.
Okay.
Madam, enabled, please.
Yeah, 1 minute. Hold on. One minute.
Yeah, we're able to see it, Karpagam.
Yes. Fine. So thank you for the lovely introduction, Dr. Preeti. So today I'll be talking about how to approach a case of uveitis. So most often, I think this game is quite familiar to all of us, which we love playing online. This is an illustrative picture with so many objects strewn across. And I think everyone loves to unravel a mystery and to kind of search for clues. And that is probably how you should approach a case of uveitis. Play the role of a primary investigator, search for clues, and finally put the pieces of the puzzle together. So how exactly do we approach? So let's just go by a step-by-step approach to find out what all is crucial to identifying the cause and come to a diagnosis. So first of all, the age and demographics of the patient, the age and from where he's coming from, the laterality, unilateral or are both the eyes getting involved, the onset, whether it's acute or insidious, the course of the disease, symptoms, signs, location. So based on this, after we have a total examination of all these factors, never miss out the systemic examination as well. So we know that the SUN classification, which basically stands for Standarditis Uveitis Nomenclature, describes uveitis based on the onset, the duration, and the course of the disease. The onset can be sudden and insidious. The duration can be classified further into limited and the persistent. The limited where the disease lasts for less than 3 months, and persistent where the disease lasts for more than 3 months duration. The course can be classified accordingly as acute, recurrent, and chronic. Now, acute meaning the episode is characterized by a sudden onset and is of a limited duration. Recurrent, in which the episodes are separated by periods of inactivity without treatment for more than 3 months in duration. And when the relapse is within 3 months, less than 3 months of duration, it becomes a chronic disease. The symptoms of the uveitis is very, very particular to the location of the disease. If it's an anterior uveitis, you're going to have pain, redness, photophobia, and watering. If it's going to be an intermediate uveitis, floaters and metamorphopsia can also lead on to defective vision. A posterior uveitis will have features of diminution of vision, floaters, and metamorphopsia. Now, based on this, we know that if the primary site of inflammation is going to be the anterior chamber, we have iritis, iridocyclitis, and anterior cyclitis, which can be clubbed under anterior uveitis. If vitreous is going to be the predominant site of inflammation, producing something called a pars planitis or a posterior cyclitis, we know it is termed as intermediate uveitis. And when the primary site of inflammation is the retina or choroid, we call it as a posterior uveitis. And the manifestations can be in the form of choroiditis, retinochoroiditis, chorioretinitis, retinitis, or neuroretinitis. So what is exactly needed is a very good detailed slit lamp examination, and never forget to do an indirect ophthalmic examination for all the patients. And ultimately, you just have to put it together in your brain. So the anterior, moving on further into how to diagnose a case of anterior uveitis. This is basically an involvement of the anterior chamber with iris and ciliary body. It can be further classified into clinical, morphological, anatomical, and etiological causes. And when you start examining from the front to back, the first and foremost, or which excites anybody, is the keratic precipitates. These are basically aggregates of inflammatory cells on the corneal endothelium due to the convection currents. And they can be arranged in typical form of a triangle known by the name as Arl's triangle, or it can be distributed in the form of a line where it's known by the term as Turk's line. It can be pathologically classified further into granulomatous etiology or a non-granulomatous etiology. This is the typical Arl's triangle. And these are the cases where we see different cases of non-granulomatous, granulomatous involvement, stellate capillaries where it is diffusely strewn across the endothelium, and the capillaries can also be little pigmented. The Sun also came up with the working classification, and in this, the field of examination is kept in high magnification, and the field size is set into 1 into 1 millimeter. And the grade of cells seen in the anterior chamber can be graded from grade 0 to grade 4+. The presence or the absence of hypopyon must always be mentioned separately. Moving further, we also have to grade the flare. 1+ where you have faint involvement, 2+ where the aqueous shows the moderate moderate involvement, with the iris and lens details are relatively clear. In 3+, there is a marked aqueous humor involvement, and the iris and lens details are hazy. In 4+, the reaction is quite intense, with you can see a fibrin or the aqueous being plastic. Moving on, we know that when there is a hypopyon, there are a list of things which must run into our mind. It could be an ankylosing spondylitis, Behçet's, infection, lens-induced, or a malignancy. And when you're going to spot a hyphema or blood in the anterior chamber, what you should think of is a viral uveitis, trauma, malignancies, flukes, chronic uveitis with dubiosis, or any other long-lasting uveitis, and following an anterior chamber tap. Now we know that sometimes uveitis need not always have a red white. There are cases of white eye uveitis, and this should come into your mind. It could be a pars planitis, it could be a Fuchs, it could be a JIA, it could be a Posner-Schlossman syndrome, other white dot syndromes, toxoplasma, toxocara, and masculates. Basically, the posterior uveitis can also present as a white eye uveitis. Moving on to the iris, what you have to carefully look for are these nodules, which can be spotted either on the pupillary margin or on the surface of the iris. So when they are located at the pupillary margin, they're known as Kopes nodules. They basically arise from the ectodermal surface. They are grayish white, and they ultimately lead on to the formation of posterior synechiae. However, with treatment, they subsequently disappear. Whereas the nodules which are located on the stroma of the iris are known as the Busaka nodules. They are situated in the collarette, and they arise from the mesodermal surface. They have a yellowish tinge to them and may become organized and hyalinized with treatment. You should also look out more carefully for the vessels which can be seen on the iris stroma. The vessels which are radially arranged and do not cross the scleral spur and do not leak on fluorescent angiography are basically the normal iris vessels, which become visible because of iris atrophy. Whereas if you start seeing vessels which resemble a bud like a glomerulus, and it has a tendency to cross the scleral spur, and they tend to leak on fluorescent angiography, that's when you know that it is a neovascularization of the iris. Synechiae, of course, you know, posterior synechiae can result because of the Kopes nodules, which we were discussing earlier. It can lead on to the formation of occlusio pupillae, and sometimes the entire pupillary area can be covered by a membrane, giving the term seclusio pupillae. Iris atrophy is also a pattern which we have to observe, and if it's going to be sectoral, the most common cause is because of a Hetzedo or a herpes zoster ophthalmicus, where you can have a sectoral iris atrophy, and diffuse iris atrophy can also be seen because of a long-standing case of uveitis. Heterochromia, most commonly seen in a case of Fuchs. However, in our population, because of the dark pigmented nature of the iris, there is a change of pattern rather than heterochromia to be observed in Fuchs cases. Ectropion UVEA is another finding. Going on to the lens, look out for complicated cataract, which may have a typical polychromatic cluster and is described as a breadcrumb appearance. And we also look out for steroid, because certain patients may already be on certain steroids, and typically there is a posterior subcapsular cataract which could be steroid induced. Glaucom flecken, which kind of gives an indication that there would be some bouts of pressure which the patient has been having during his attacks of uveitis. And also, if it is going to be a pseudophakic patient with a thick plaque, never forget to look out or suspect P. acne and ophthalmitis in such cases. Now, the intraocular pressure, we know that in any acute uveitis, there could be a primary shutdown, ciliary body shutdown, which results in a decreased IOP, or when the eye is going for a thysical stage. And in any case of inflammatory glaucoma, steroid-induced or trabeculitis, and iris bombay and secondary angle fossa glaucomas, they can be in raised IOP. So it's not necessary that it should always be low IOPs in uveitis. It could be low and high, and your costs will accordingly vary. Gonioscopy is very, very crucial, and it can help to come up with a lot of diagnosis. Look out for synechiae, especially when it is going to be broad-based. It gives an idea that it could be some granulomatous disease like sarcoidosis and tuberculosis. There could be some foreign bodies. There could be some exudates in the angle. There could also be blood or hyphema in the angles alone. Moving on to the posterior uveitis, where we're talking about inflammations which involve the choroid, retina, and the optic nerve. Can be further classified into chorioretinitis with vitritis and without vitritis. retinitis, choroiditis, retinochoroiditis, and neuroretinitis. So the basic confusion when we see any lesion in the posterior chamber is whether it's a retinitis or choroiditis. A choroiditis patch is typically grayish yellow and has got a fairly demarcated borders, and retinal vessels are normally seen over it. Whereas a retinitis is a white cloudy patch, outlines are indistinct and the retinal vessels are not clearly seen. Most often there would be a combination of choroiditis and retinitis, so that's why we term as chorioretinitis or retinochoroiditis when we see clinically. The grading of vitreous cells, NIH has come up with a grading of vitreous cells which can be seen in the anterior vitreous phase with a slit lamp itself. So from 0 to 4+, this is the grading which we follow. Also look out for snowballs and snow banking, which can be ideally seen by indenting at the pars plana region. Need to find out there are certain lesions or etiological causes when posterior uveitis presents with vitreous cells. Think of more commonly infectious causes like toxoplasma, toxoplasmosis, and then move on to the further causes like sarcoid, TB, nocardia, and cat scratch. When we see without any vitreous cells, you more think in line of tumor or serpiginous choroidopathy. When the posterior uveitis is having multifocal lesions, again, you can further classify with and without vitreous cells. With vitreous cells would be asymptotic ophthalmia, weakate, sarcoid, malignance, rubella, birdshot, and all the white dot syndromes. Whereas if you don't see the without vitreous cells, it could be an ocular histoplasmosis, TIC, retinal pigment epitheliitis, SSP, and serpiginous choroiditis. Again, retinitis can also be further classified based on whether it's going to be focal or multifocal. Focal lesions in toxo, cystic circus, and masquerades more commonly here in our country. And it's going to be multifocal retinitis. You have to think of all the viral etiologies, basically the HSV, HZV, VZV, and CMV, followed by the other diseases. When you have posterior uveitis with vasculitis, what you have to really look at is whether it's going to be an arterial involvement or the veins are going to be involved, or is it going to be the arteries and veins. So most commonly SLE, and pansyphilis, the viral have an arterial involvement, whereas sarcoid and Behçet's, which is most commonly seen, have a venous involvement. When both arteries and veins are involved, we have to think in terms of relapsing polychondritis, vaginous, Crohn's, and frosted branchitis. This is a typical case of frosted branch, and of course, this is just a finding. The DD could be a lot much more. The candle wax routine, I think Dr. Divya Ashok already showed these typically characteristic of sarcoidosis patients. Also look out for any serous detachments, ileum folds, Dallen nodules, especially in long-standing uveitis, cotton wool spots, CNVM too. So it doesn't mean that once a uveitis patient, especially with the posterior uveitis, is treated, we just have to let go and do not follow, because what can happen in due course of time is the patient can develop a choroidal neovascular membrane, and hence a thorough and a proper follow-up is quite essential in these kind of patients. CME is a complication which happens usually in untreated or long-standing uveitis. The optic disc is not to be missed. Look out for edema, any granuloma, and neovascularization of the disc. So when we see a typically inflamed or a hot disc with ileum folds or a serous detachment, what comes to our mind is a neuroretinitis. So the differential diagnosis would be Toxoplasma toxocara, the viral uveitis, syphilis, sarcoidosis, cystic circus in Canada, and Lyme's and lepto. Never forget to have a thorough systemic examination, which includes a detailed examination of all the systems. Like in this case, when you're suspecting the patient is having an altered posture, could be because of a sacroiliitis in HLA-B27, in rheumatoid arthritis, in JA, a depressed nose could be seen in cases of sarcoid, vaginous, syphilis. So all the systemic examination is quite crucial. In rheumatologic, look out for arthralgia, low back pain, joint stiffness. Skin, look for rashes, sores, alopecia, vitiligo, poliosis. Neurological, look out for tinnitus, headache, meningism, paresthesias, weakness, and paralysis. Respiratory, always ask for history of shortness of breath, cough, and sputum production. In GI, it could be diarrhea, bloody stools, aphthous ulcers, and the genitourinary complaints. There was also a history to be elicited if the patient is IV drug abuser, has any pets at home, especially cats and dogs, any history of recent travel, any history of stents placed in the body. So when we see a case of uveitis, we also look out for jump for something which is not quite the ordinary, right? So this is something which is not quite the, it's an animal which is found very, very rarely, but we just try to look out for these things. The day-to-day life, when we see patients in the OPD, these are the cases which we see. it could probably meet the more common, like the monkeys which we see all around. So in our country, we would still lay the prime focus on TB and sarcoidosis and infections rather than jumping onto some hi-fi diagnosis. So there are certain things which we should know before closing off. When we see a geographic map-like pattern, what we must come across or think is the serpiginous choroiditis. When we see typically the headlight in the fog sign, think of toxoplasma retinochoroiditis. Of course, the pizza pie, classic of a CMV retinitis. Sunset glow fundus is a case which we see in BKH. A cracked mud appearance is typically in a case of progressive outer retinal necrosis, and a frosted branch iriditis, because the differential diagnoses are many in this case. Candlebat stripping or tag de sign is typical of sarcoid uveitis. So thank you so much, Kalpa team, for giving me this opportunity. And if there are any doubts, I would like to take them now, please.
Thank you, Dr. Karpagam, for being a constant person in our Kalpa team. I think that was a beautiful presentation, and it was, you explained an approach to uveitis in a very systematic manner so that I don't think anybody would miss out a single finding after your talk. Thank you so much, Karpagam. I'd like to call upon Dr. Divya Ashok ma'am once again for our next topic, which is on ptosis.
Yes, can you hear me?
Yes, ma'am. We can see your slides as well.
Yeah. So in the ptosis in exam case, in your practicals, clinical evaluation is important. Before going directly, we should know the anatomy. We all know that LPS is the muscle which elevates the lid, and it originates from the sphenoid bone from the apex near the optic foramen. It comes out as a thick muscle. Then it turns out to be an aponeurosis, gets attached to the tarsus, gets few fibers attached to the skin, forming that crease, and the lateral and medial horn is also that is supplied by the oculomotor nerve. So whenever you see the ptosis patient, you always get the history of the onset, progression. These are the symptoms. We have to look associated symptoms. Any diurnal variation from morning to evening, is it changing? Associated diplopia, any previous history of trauma, is it associated with visual disturbances? And asthenopic symptoms, that means prior to the ptosis, whether the patient had any weakening or any pain, fatigueness in the eye, chronic allergy, redness, itching, all these things you have to ask. Ocular deviations associated with squint, abnormal movements like movement of the jaw, the movement of the lid while moving the mouth while eating, and ocular surgeries, previous history of VR surgery or cataract surgery. Pediatric, you can ask for the forceps delivery, and family history, especially in blepharophimosis. Generalized weakness in systemic myasthenia, you can have dysphagia, dysarthria, muscle weakness, and dyspnea. Contact lens wear, because contact lens again in cause for mild ptosis. Injections like ptosis and drug intake should be asked. In evaluation, you always look for few clinical dimensions in OCT. So in ptosis, here you see here the MRD1 is calculated from the center of the reflex to the upper lid. It's MRD1, marginal reflex distance 1. 2 is from the center to the light reflex to the lower lid margin, is MRD2. So always measure the vertical fissure height. In ptosis, there is reduction in the vertical fissure height. Sometimes the reflex is getting covered, as you can see in the left side. There is ptosis and the reflex you cannot see. So lift the lid. If you lift the lid, it is called negative MRD. You put minus and you write the marginal reflex distance. So marginal reflex distance, fissure height you measure, then you measure the tarsal height. This is the patient with the increase in the pre-tarsal height. You can look for the MCD, that is marginal crease distance. And sorry, it was gone. One second. Yeah, here you can see the marginal reflex distance here and compare it with the other eye. Look for the lid closure, and you have to look for the LPS function. You give pressure on the frontalis and ask the patient to look down to up. So when you ask the patient to look down, you can measure the LPS with action with the ruler. So this patient is having actually good LPS function, as you can see. And look for the Bell's phenomenon, extraocular movements. Patients can have deficit in elevation because the superior rectus muscle may be involved in the congenital ptosis. So always look for the extraocular movements, lid closure, complete lid closure, and look for the skin fold, the dermatocalluses or blepharocalysis excess skin fold. And you can all see the elevated eyebrows. That means the frontalis overaction is there. The patient is trying to lift the frontalis. And here you see the patient is not able to lift more. That's a poor levator function. And she also has elevation deficit. See that elevation, she's not able to elevate the eye. Goes downwards and late adduction, abduction is normal. So this patient also had a Marcus gun phenomenon. If you ask the mouth to open, there will be movement. If you have to look for the Bell's, always ask the patient to close the eye and see that eyeball moving upwards. Sometimes they can have the eyeball moving other direction. As you can see in this patient, she has an inverse Bell's moving in downward direction. Sometimes it can move in other direction. It's called perverse Bell's. Bell's can also be defined as poor, fair, depending upon the amount of cornea being exposed during the Bell's phenomenon. Ask the patient to open the mouth and give jaw movement. If she has any Marcus gun phenomenon, you can see the left lid is moving up. This is because of the connection between the pterygoids and the LPS, that is congenital nerve innervation. Should always look for the mechanical causes. As you can see here, this patient had this hydrocystadenoma underlying. So elevate the lid and see in all the patient, and look the marginal distance in the up gaze also. Ask them to move in the other direction. Suppose they can have this other syndromes associated. They can have the movement in the adduction and abduction, lifting the lid, like in aberrant third nerve degeneration. Close the affected eye and see if the other eye is drooping, because these patients can have compensatory lid retraction, as you can see in this patient. So always patch one eye and see whether the other eye is drooping down. So you explain to the patient after surgery what happens to the other eye. There can be mild droop in the other eye, about 1 mm, because there is a compensatory increased retraction due to Hering's law. Eye SPAC test we routinely do to rule out myasthenia. It's a positive eye SPAC test clinically tells us that the patient might be having myasthenia, and do the evaluation. So other clinical evaluation we do for the patients includes visual acuity, pupil examination to rule out Horner syndrome, which can be combined with meiosis and ophthalmos and ptosis, and corneal sensation for all patients, because there could be the anesthesia involved. These patients can have lag of ophthalmos, so we don't have any anesthetic corneal anesthesia leading into ulcer postoperatively. Retinal microscopy should be done in all patients. Retinal evaluation is important because they can be associated with retinal pigment changes, especially in CPUO. Specific test wherever indicated. Suppose in a patient of myasthenia, you can do clinical tests like fatigue test, sleep test, or a Cowan twitch sign to find the difference. Diplopia charting can be done if the patient is having double vision. And phenylephrine test to instill phenylephrine in the eye and see for the elevation. It is usually to stimulate the Muller's muscle, which can be there in patients. If it is elevating, that shows the patient can get benefited by the Muller conjunctival resection. Neurologist opinion and pediatric opinion, MRI, are specific only in few cases. So other dimension you have to look for in patients are the intercanthal distance, which may be altered in telecanthus. Patients with blepharophimosis, they have increased intercanthal distance, and the interpupillary diameter and the outer canthal distance. So this all can get affected in blepharophimosis. So in telecanthus, you see there is increased ICD, while in hypertelorism, where the entire bony orbit is widely placed, all the parameters are increased. ICD, OCD, and IPD is increased. Tensilon test, the clinical evaluation, it is not routinely done nowadays. Previously we used to do. But for the theory aspect, we should know how it is being done in adult patients, where we give the neostigmine IM and observe for the improvement of ptosis after 5 minutes. Alternatively, you can give edrophonium. Whenever you inject, you always load it systematically, like 2 mg slowly, and look for the ptosis. If it is improved, let's say it is positive. And if they can develop some cholinergic reaction, then you have to give atropine. Always keep atropine in hand. Phenylephrine test we just explained. So positive phenylephrine test shows there is a molar muscle repair can improve the ptosis. Depending upon the degree of ptosis, we classify it as mild, moderate, and severe. To 2 mm, it is mild, moderate is 3 mm, severe is 4 mm and more. And LPS function also, as I told you, that you can classify according to your clinical evaluation, like poor, which is less than 4 mm, fair is 5 to 11, good is 12 to 14, and normal is more than 15. And depending upon this LPS action, there have been various studies which have been given, protocol surgeons have given how much LPS resection can be done for patients. So the LPS resection protocol also changes according to your unilateral ptosis or the amount of ptosis the patient is having, whether it's simple or complicated. In myasthenia patients, you do other evaluation, like you do the antibody for the acetylcholine receptors, because it's an autoimmune antibodies against the receptors, which is preventing the muscle to contract, and anti-musk antibodies. Can do hydrophonium test. You have to do a single fiber electromyography or repetitive nerve stimulation to look for the detrimental response in myasthenia. And in patients with CPO, where you see the bilateral ptosis, you have to do an ECG to rule out cardiac complications, ERG, electromyography, and mitochondrial assay. Patients can have associated thyroid abnormalities, so we have to do a thyroid profile, and where you suspect a high antibody profile, you have to look for thymoma, so do a CT chest to rule out thymoma. Coming to the classification, depending upon the etiology, classify it as congenital ptosis, could be simple or complicated with the superior rectus underaction or double elevator palsy. It could be complicated by blepharom or phimosis syndrome. With the syncretic ptosis with aberrant neural connection, Marcus jaw-making phenomenon, misdirected third nerve ptosis. In acquired ptosis, it could be myogenic like myasthenia or CPEO, neurogenic due to third nerve palsy or ophthalmic migraine, mechanical due to lid tumors, aponeurotic due to senile process, and traumatic. Pseudotosis is there is no true ptosis, but because there is a other condition which is apparently appearing, making this eye to appear drooped. So that is called pseudotrosis. What are the conditions? If you have the other eye which is enlarged or contralateral retraction, there is ipsilateral dermatocalcis, and the globe is not intact. Suppose the microphthalmia of one ophthalmic socket, then those conditions can be seen as a pseudotosis. In treatment aspect, if there is mild ptosis with good elevator action, you have to do a facial servant procedure. It's a minimal resection of the tarso-molars conjunctival muscle. In moderate ptosis with good function, you can go for levator resection. In severe with poor function, you have to go for sling procedures. There are other specific conditions wherever you have this aberrant regeneration markers, then you have to go for the LPS disinsertion with frontalis sling. And depending upon the associated findings, suppose the patient is having blepharophimosis, you have to correct the canthal surgery first, do the telecanthus repair, YV-plasty or translational wiring, followed by ptosis after 6 months. Third nerve palsy, you have to go for squint correction first, followed by ptosis. Other causes like myogenic, you have to treat medically, and mechanical ptosis, you have to treat the cause in pseudotosis as well. So the sling procedure is commonly done for the poor LPS function. You can see here the Crawford frontalis sling, where you can make the you can do a double triangle Crawford or a Fox pentagon. This is a base of frontalis sling procedures. And in LPS resection also, depending upon the mild and moderate severe category, you can do the amount of LPS resection. In a mild ptosis, you have to keep it under corrected, and in 3 mm to moderate, that is level, we match the level in the normal intraoperatively. If it's a severe case, you little over correct it intraoperatively. This is a sling procedure which I am showing. So you make the mark above the eyebrow 10 millimeter, local anesthesia is made. 2 other supra eyebrow marks are made at the outer and inner canthus. The lid margin, the site will be around 3 mm from the lid margin. Infiltrative anesthesia is usually given. To make the patient cooperative, you can make them sit on table and see. So silicone sling can be used or facial ETA can be used. Here the silicone sling is being used. You introduce it suborbicularis plane, bring it out at the lid margin. So finally you bring the silicone sling, you attach the sleeve. So tie it and place it in subcutaneous plane and you can close it. the frontalis sling, and you have to suture the skin. So you can also use a single stab incision for the sling. So here you make a small single stab here. Instead of making the 5 positions, you just make single stab, and you guide your finger to move your needle across the suborbicularis plane. The method is same, but instead of bringing it out, you just go it in the same plane, avoiding the eyebrow lid incision. So it is the pentagon which is coming out. To change the direction, guide it. So same way it is brought out. Yeah, this is the single, the same sleeve is being used. This is the other way of doing the frontalis sling, reduces the scarring. In LPS application resection, you make the incision in the this superior plate crease incision, identify the tarsus and dissect it, connect the LPS. So if your LPS is separated, then there is a traction suture placed. This is a non-absorbable suture, proline suture is placed, and the LPS is dissected. Yeah, then you form a crease. So this is the post-operative period of the patient after the LPS placation. In facial servet is a tarsomullarectomy where you can as you can see here, the upper tarsal border you make the traction sutures, the lower border, and they cut the tarsal mullarectomy. Tarsoconjunctiva is then suture. So in mechanical ptosis, you have to treat the cause whenever there is hemangioma. This is a capillary hemangioma after propranolol treatment. The lasik or tarsal cyst, that has to be treated. In pre-post after the dermoid excision, you can see the difference in the doses. The contraindications or absence of blink reflex or corneal sensitivity is lost, the absent Bell's phenomenon, and severe dry eye, they are contraindications for the ptosis correction. Medical management, you can give crutch glasses for these patients, and haptic contact lens with shelf can be tried. There are other techniques like where they can magnetically keep the metal implanted in the upper lid, and to keep the lids open for elevation can be tried. This is the crutch glasses for the patient with bilateral ptosis, where this patient is not in this. We are not planning for surgery. You can go for crutch glasses. In myasthenia's additional treatment, you have to provide the pyridostigmine treatment, which are given BD or TDS by the neurologist under steroid. Immunosuppressants are also added. Thymectomy should be given in thymoma, and plasmapheresis in systemic and IV immunoglobulin wherever needed. That shows the workup of the ptosis.
Thank you, ma'am. Thank you for those wonderful videos and that lucid evaluation. So now we have Dr. Preeti Uday again to talk about ectropion and entropion.
Good evening once again, and I will go through the entropion and ectropion. So ectropion, as we know, is outturning of the eyelid margin, and we have various kinds like acquired and congenital. Acquired, it can be involutional, which we most commonly seen, and or it can be mechanical, cicatricial, paralytic. And congenital can be because of shortage of skin or certain conditions like ichthyosis. Now, this is how an involutional ectropion looks like. It is age related, and there will be laxity most likely, horizontal lid laxity. So that you check by doing the pinch test and the snap test. I will show you how to do it. And the medial canthal tendon laxity may be there along with lateral canthal tendon laxity in these patients. The other kind is cicatricial, in which it can be because of shortage of the anterior lamella. So you must know the three lamellae in the eyelid. The anterior lamella is the skin and the orbicularis. The middle lamella is the tarsus and the retractor muscles. And the posterior lamella is the conjunctiva. The tarsus and the conjunctiva, some people include in the posterior lamella. So whenever there is a shortage of the anterior lamella, you will have ectropion. Okay. Now this can be because of either trauma. So if you have a scar there, like in this patient, you can have an ectropion, or that anterior lamella can be shortened because of burns or because of previous surgery, like blepharoplasty. This is very commonly seen when blepharoplasty is done with a transcutaneous approach. Therefore, now we mostly do blepharoplasties with a transconjunctival approach. It can also happen following tumor excisions in the anterior lamella. And it can be seen because of dermatological diseases which cause scarring of the skin and the orbicularis. Another cause of ectropion can be paralytic, wherein you see it in facial palsy patients. This is a patient with bilateral facial palsy. Now, coming to history, of course, you need to know whether it's unilateral, bilateral, it involving one lid or both the eyelids, and the duration, like days, weeks, months, years. And of course, the onset, duration, and progress will tell you whether it's acute or it's been there for some time. Now, this is how a typical post-burn patient looks like. You can see the anterior lamella, that is the skin, and the orbicularis is scarred and shortened, and that causes the outturning of the lid margin. Now, symptoms, you can have symptoms because of any eyelid mass that is present on the skin, or it can be because of lack of eyelid closure because of the ectropion, and that can cause an exposure and cause redness, watering, and also you can see other symptoms. If there is paralytic, you will see weakness on one half of the face. Now, when you look at the eyelid, you must see what is the extent of the ectropion, whether it is very localized or it is a generalized ectropion involving the entire eyelid. Most likely, whenever there is an ectropion, there is a lot of symptoms because of punctal eversion. So look at the punctum, especially in senile ectropion, and if that is everted, you need to correct that for the patient to get relieved of the watering. Now, if there is ectropion for a long duration, then the conjunctiva, the exposed conjunctiva, gets congested, and with time it can get keratinized. And you can see the cause of the ectropion, like you can see scarring on the eyelid, or you can see erythema, or of course you need to look at the cornea for any SPKs or any exposure changes. Now, general classification is it is mild when there is mild turning of the eyelid margin and lashes or the punctum. Grade 2 is when the palpebral conjunctiva is exposed, and grade 3 is when the fornacial conjunctiva is exposed. So this is how some of the patients look like. This is a typical scar in the skin, and that has caused a very localized ectropion. And when there is a localized ectropion, you can correct it with a Z-plasty, like we have done here, a Z-plasty. Now, another patient, this second one is because of severe burns, and in these kind of cases, you need to do a skin graft only. Now, the donor sites for skin grafts, you can take post-auricular, which is most commonly taken for a full thickness skin graft. If you want a split thickness skin graft, you can take from the anterior part of the thigh or the medial part of the arm. Full thickness skin graft, you can also take from the supraclavicular area, which is a very good donor site. So these are some of the patients who have very localized ectropion. This is how a skin graft is done. We incise in the infraciliary area. We separate we remove all the scar tissue, and then make a template to see how much of a graft we require. And then we harvest the graft and suture it, and then immobilize the graft with the help of a bolster so that the graft take is good. Now, for involutional ectropion, the commonest reason is laxity, and therefore you correct the laxity. If it is diffuse, then you do a Kuhn-Zemanovsky's procedure or a lateral tarsal strip. And if it is focal, like if it is medial canthal tendon or lateral canthal tendon involvement, those tendons can be plicated or tightened. So these are the few procedures. Now, Kuhn-Zemanovsky is you take a full thickness pentagon of eyelid skin and remove some of the excess of skin, because this is a senile entropion, there will be skin laxity. So when you reduce the horizontal length of the eyelid, you will have some excessive skin which you will need to remove with a blepharoplasty skin incision. just whenever you have a localized ectropion, that is just the punctum is everted, you can take a diamond of conjunctiva, excise it just below the punctum medially, and that will help you to invert the punctum. And when you combine this procedure with a full thickness pentagon excision, it is known as a lazy T procedure. If medial canthal tendon is lax, you plicate that, but one must be careful because sometimes it causes kinking of the canaliculus. So the extent of plication has to be titrated accordingly. Now, mechanical ectropion, of course, the cause has to be treated. If there is a tumor or some mass on the anterior lamella, you need to excise that. But very often you find that there is also horizontal laxity associated with that, and you need to do the pentagon excision or a lateral tarsal strip along with the excision of the mass lesion. Lateral tarsal strip, all of you know that a strip of tarsus is found on the lateral side of the eyelid, and that is anchored to the periosteum at the superolateral margin of the orbit. That is the commonest procedure that we do for any of these eyelid margin malpositions. Now, coming to entropion, entropion is interning of the eyelid. So obviously, when the eyelid margin is turning in, you have a problem with the posterior lamella most likely. So ectropion problems are more anterior lamella related, and entropion problems are more posterior lamella related. Now, whenever you examine a patient with entropion, you must examine the patient in such a way that you know what to do with the patient, that is what procedure you need to choose. Okay. So you need to know what kind, the types of entropion, that is, it can be congenital or acquired. Acquired, most commonly we see is senile entropion. We can also have cicatricial or spastic entropion. So again, in history, the same history: unilateral, bilateral, upper or lower eyelid, onset, duration, and progress. And symptoms, these patients with entropion are very, very symptomatic because these eyelashes are now rubbing on the ocular surface, and that can cause corneal abrasions, corneal SPKs. You can have watering, redness, and patients are very, very miserable in these conditions. So temporarily, to relieve these patients, you can give them lubricants and temporary taping of the eyelid. That is, you apply a tape on the skin so that the eyelid margin is everted till the patient is prepared for a definitive procedure. Of course, you need to check the vision of the patient for documentation. And of course, you need to look at the lid, at the inside of the eyelid, and look at the conjunctiva, whether there is any signs of cicatrization like thickened tarsus, or you have congestion or thickened conjunctiva, or symblephron, ankyloblephron, or scarring. Now, how do you examine a patient with lid laxity? So you need to do a distraction test. That is, you pull the lid margin and see whether you are able to pull it away from the globe by more than 6 millimeter. That is a positive distraction test. A snapback test, that is, you pull the eyelid down and it should snap back without a blink in a normal patient. If it does not, then the lid is lax. You can have a lateral canthal tendon laxity, that is, you are able to displace the lateral canthus by more than 2 millimeter. If you are able to displace the medial canthal tendon by more than 2 millimeter, it is a lax tendon. And the lower lid retractor is very much important in keeping the tarsus in position. So if you have a lower lid retractor dehiscence, you need to examine for that. So lower lid, whenever the eye looks down, the lower eyelid also should move down. When the lid margin does not move proportionate to the eyeball, that means you have a dehiscence of the lower lid retractors. Sometimes when you evert and see the conjunctiva on the inner side, you'll be able to see a white line. That is the dehisced margin of the lower lid retractor, you will be able to see. And of course, in senile entropions, the commonest sign that you see is overriding of the preseptal on the pretarsal orbicularis. This is what you can see in this old lady here. So these are all the signs and symptoms that you need to see. You need to also look at the fornix for fornication shortening, and look at the lid margin for trichiasis, dystrichiasis, because very commonly you have entropion secondary to chemical injuries, and you will have other signs of injury like trichiasis, dystrichiasis. You can have a thickened tarsal plate, and these things have to be looked at because your treatment then will depend on these symptoms. Now, coming to congenital entropion, you have two kinds. Whenever the lid margin is inverted, it is known as an entropion. But if the lid margin is in position, but you just have eyelashes rubbing on the eye, then it is an epiblephron. So epiblephron is generally because of excess of skin and muscle. Usually the children have very huge cheeks, and with age, as the face grows, that gets corrected by itself. And usually the eyelashes which are rubbing on the corneal surface are very fine. They do not damage, they do not cause any SPKs or aberrations. And we just give lubricants to these children and they are able to manage for some time till the facial growth is complete. But if you want a definitive procedure for these patients, you need to excise the skin and muscle from the anterior lamella, which leaves a very visible scar on the face, and we try to avoid that now. And in most of the patients that I see, small children with these kind of epiblephrons, I like to give dermal fillers and stretch the anterior lamella in such a way that the eyelashes evert. So the first treatment would be just lubricants if there is no corneal problem. If there is a corneal problem, you try with dermal fillers. If that doesn't work, then you need to do this Holt's procedure. In so many years of my plastic practice, I haven't done a single case Holt's procedure because it causes a lot of scarring and a bad visible scar. Now, this is one of my colleagues' slide where the Holt's procedure is seen. You make an infraciliary incision and you can see the fine sutures here. You excise some of the skin and the muscle and then reattach the orbicularis to the tarsus so that the lower border of the tarsus is everted. Now, when you have acquired entropion, if it is senile, it is usually because of laxity, so you correct the laxity. Horizontal laxity, the MCT as well as the LCT laxity. If it is cicatricial, it is usually because of chemical injuries, Stevens-Johnson's, trachoma. You correct these conditions in the acute phase, and in the chronic phase, the sequelae has to be then dealt with various surgical procedures, which I will discuss soon. And spastic entropion. Now, spastic is generally because of some ocular surface problem, like you have corneal SPK, epithelial defect, the patient is squeezing the eye all the time, or if he has been patched for a very long time, patching induces this kind of an entropion. Or if the patient has a nerve problem like hemifacial spasm, blepharospasm. So because of constant spasm, the eyelid margin turns inside. So these patients, how do you diagnose this spastic entropion is just put topical anesthesia. That will correct all your ocular irritation problem and that will correct your entropion. So in the exam, if you're doubtful about a spastic entropion, just put topical anesthesia. If the entropion gets corrected, it is a spastic entropion. You need to treat the primary cause in these patients, like you correct your ocular irritation. If there is a blepharospasm, you need to give Botox to the patient so that the spasms gets relieved, and patching should be avoided in these kind of patients. So this is typically how a senile entropion looks like. This bulge here is the overriding of the preseptal over the pretarsal orbicularis. Now, coming to the treatment, depending on the pathology. So if you have an override between the preseptal and pretarsal orbicularis, you need to create a scar in between the two. So what you can do is either use a lid everting suture. This is very temporary. We do it in patients who are not ready for surgery, but it does recur with time. Basically, you pass a suture deep into the fornix and then come out into the anterior lamella just below the lid margin. So this creates a scar pathway along the suture and prevents this overriding of the preseptal over the pretarsal orbicularis. And the other procedure is Weiss procedure. Again, this is abundant now because it creates a very bad scar, and very often you have an overcorrection. That is, you land up with an ectropion, and that ectropion is very difficult to treat because now you have a very thick, full thickness scar in the infraciliary area. But this is one of our old slides where we have done a full thickness lid split and then everting suture, which is the Weiss procedure. When you combine this Weiss procedure with a horizontal lid shortening, it is known as a Quicker's procedure. Most commonly, you don't find one isolated pathology, like you won't find just the overriding of the preseptal over the pretarsal. Very often that will be combined with the horizontal lid laxity, and very often you will need to combine it with a lid everting suture. So this kind of a quicker procedure is more commonly done compared to a Lee's procedure. Then in some cases you will need to rotate. So depending on the tarsus, if you have a cicatricial ectropion, if your tarsus is thick, you can do a tarsus wedge or you can do a tarsus rotation. Now in these kind of patients where the tarsus was thick, I have done a marginal rotation along with a pivoting suture and anterior lamellar repositioning. When there is just a lower lid retractor dehiscence, you need to find the lower lid retractor, which is similar to the levator muscle in the upper eyelid. This is the fat pad which is there behind the septum. Once you separate the fat pad, what I am holding with my forceps is the lower lid retractor. It is a very thin muscle and you need to reattach that muscle to the tarsus for you to correct the entropion. So cicatricial entropion is a little more difficult to treat, and depending on your findings, you need to find your procedure. So if the tarsus is thickened, a tarsal wedge resection helps. If the lid margin is keratinized, you need to rotate the margin outwards. And if there is severe shortage, you need to do a graft. So the graft you can take either from the cheek or the lip, that is a mucous membrane graft, or you can take a hard palate graft and use it as a spacer to increase the length of your posterior lamella. In all these procedures, you should also recess the levator. You can see here that the levator is recessed, otherwise the lid doesn't come down to its normal position in spite of using a lot of grafts. So that was it in short about ectropion and entropion. If there is any questions, I can take it. Thank you so much for your time and attention.
Thank you, Dr. Preeti. I think that was a large topic. We had you cover it in 15 minutes for us in a very concise manner. And thank you so much for being with us. And if there are any questions, we would get back to you. But in the meantime, let's go on to our next topic, which is on ophthalmic instruments by Dr. Divya Ashok again.
This is a relaxation session, huh? In between all the topics.
Yes, ma'am.
So that's why. The instruments, I think in your exams, you will be having a separate viva in instruments. So you should be familiar with the instruments. I request all the PGs who were the junior people who are seeing to be familiar with the instruments you are using, like you are doing a cataract surgery or a DCR or a chalazion. Just see the instrument, go and read what it's about. Let us start from this common instrument, which is the wire speculum, which is usually we use for the routine purpose like cataract or whatever squint surgeries, VIA surgery. It's a wire speculum. So it goes by the name Barracoeur, and there's not much complication with that. It's a wire made, so you can have a blade also present in the instead of the wire, you have the blade form, which is protective. As compared to the wire, we have a pediatric version of this wire form, which is triangular instead of this pentagon form. So you can have a hemostatic retractor with screws, self-retaining speculum also, that is the Castroviejo type. Here you can see where you can titrate the amount of opening of your palpebral aperture. So you should be careful whenever you give tightening of the screws. If you excess tighten, you will injure the muscle superior rectus and LPS. Sometimes these patients can have post-operative ptosis because of pressure. Coming to the forceps, this is the plain non-toothed forceps. Usually hold non-traumatizing tissues. If you want to hold, always look into the tip of the instrument. You look for the tip. Here you can see the Pierce forceps. See, this is toothed forceps. Whenever somebody gives you an instrument, look at the tip, identify the toothed end, and this is a common Pierce forceps, micro forceps with toothed ends. Graphis forceps commonly we use for the fixation of the globe, especially doing the FDT. So if you are getting an instrument of Graphis, you should know how to do an FDT. So SQUINT procedure, or holding a soft tissue, especially in while doing a DCR procedure, or soft tissue in a thick muscle, when you are holding it, use the fixation forceps. An FDT globe fractures and wherever there is restriction, you do FDT. And this is the Dastur superior rectus holding forceps. If you are given a forceps like this, you look for this end, a swan neck end, where this place is for the muscle where you can just place and hold it. You just lift it. You commonly use it for the non-phaco procedures like ECC, where you hold and tie up the superior rectus. So it's where you keep that and elevated. This is a titanium. So far you saw some stainless steel instruments. The titanium instrument, the titanium advantage is less rusting and it is less weight also, easy to hold, long lasting. So the advantage of the titanium and stainless steel. It is a toothed forceps, colibri, and again it has got an angulated edge. You see that angulated edge as compared to the previous one. This is the limbs commonly used forceps. You can see that it doesn't have any angulation. It is one-toothed limbs forceps, which is used for corneoscleral, picking up your corneosclera. So this again, it has got a tape. This is a commonly used forceps. In your OPD also, you'll be using it for foreign body removal or lash removal, which is the McPherson's forceps. Again, this is the titanium. Can have in stainless steel also. This is non-toothed. You can see you can hold this intraoperatively for the IOL. McPherson can be used as a tying forceps for tying your sutures, for holding the intraocular lens intraoperatively, placing inside the bag. Foreign body removal, anything can be removed with that, which is it has a good hold and it is non-traumatizing. Artery forceps. This is artery, halstead artery, where you can use it for the tying your traction sutures to the towel. And don't think they always keep you these cataract instruments. They can keep you any instruments, SQUINT, DCR, even VR surgery, cornea, anything can be kept for evaluation. So you should be familiar with all simple instruments. So like this is a muzzle hook. The difference between the previous one and this, you can see this hook like thing here holding the muzzle. So it's Jameson. The previous was Graphis. And this is a retractor. This is a Desmes retractor. You have various sizes of Desmes retractor. Retract the soft tissue, non-traumatizing type. And this is the NAPS cat's paw. So it is a little bit traumatizing, especially retract in soft tissue or PCR procedures where you retract. This has got the paw of the cat. Now this is coming to the needle holders, the Barraco's needle holder, which you commonly use for your cataracts. See this neck, which is a little bit curved here. And the alternate needle holder is your Castrovigio needle holder, which the neck will not be very much curved. And it is larger in size. So this is the Barraco, that was the Barraco, is the Castrovigio needle holder. Barraco usually used for nylon threads. And here for vicryl and VR surgery, spin surgeries, Castrovigio. So the striations in the holding region gives you grip. That's why there are striations. This is a caliper for measurement. So whenever they give you caliper, they always ask you which procedure you will measure, especially for the pars plana vitrectomy. During the vitrectomy procedure, where will you place the vitrectomy site? Sclerotomy. So that is a very common question they will ask. Sometimes you have to measure for the ocular surface tumor. You are going to give a clearance, like you're going to give a 4 mm clearance from the conjunctiva. So that is another condition where, or intraoperatively, if you want to measure the size of any corneal ulcer or corneal diameter also, you can use this caliper. The Castrovigio caliper for the measurement. This Von Graeff's knife, previously it was an old instrument. It has been used to where that needle, this hole will be used for tying that suture into it. Coming to the keratomes, in cataracts we use different keratomes, 2.8 for we make the entry and side port entry with 1.2 with angulation of 15 degrees in the clear cornea. So when you are given the keratomes, if you are picking up a keratome, you should make sure what are the type of tunnels you make, clear corneal, biplanar or triplanar, what is good. You make a clear corneal incision, what is the advantage, how it prevents your iris prolapse. These are the questions you will be asked by your examiner. And this is a crescent which is used for the dissection, especially in the scleral tunnel dissection, or you are dissecting a scleral lamellae, especially in trabeculectomy if you want to make a flap, or in a patient with OSSN where you are taking this deep sclera, you can use a crescent knife. That is about the keratomes. Coming to the scissors, Westphal scissors, corneal scleral scissors, you can see that the flange, which is broad based. This is the keratoplasty, where you can see it is angulated, so that you can just cut through the corneosclera and remove your corneal button. Castrovigio keratoplasty angled scissors. It's a very commonly used spring scissors of the conjunctiva. And when you are doing a peritomy means you commonly use it for your RD surgeries. One second. In RD surgeries, you use it. That is where so retinal procedures where peritomy is done. So they will be asking when you take a peritomy how to take precautions for the scleral buckle and all. This is a clamp. As you can see here, it has got an open end and there is a flat end. Flat end goes towards the conjunctiva, and this is the entropion clamp. So this outer part will be on the lid. You can do the entropion procedure using this clamp. Snellen's entropion clamp for the lid procedures, and this end we can tighten it, and this end will be on the outer side. That's a temporal side. Calazion clamp is a common clamp. It is various sizes are available. It is a hemostatic clamp where you put this surface on the conjunctival and the skin surface, and this opening will be on the conjunctival surface. Once you put it, you tighten it and make the incision. They might be asking when you will do a calazion removal, and what are the precautions you take. You make an oblique incision, and sometimes you have to make a cruciate incisions. You remove that tarsal for biopsy in recurrent chalazions, especially patients with elderly. You have to rule out a meibomian gland carcinoma. These are the questions related to that. Then spatula, you do use in cataract procedures to deliver the lens. This is the wire vectors with the irrigation connected to the cannula, where you can use again in the extracapsular cataract extraction. You always look for the gauge here. Whenever they give the instrument, the gauge of that irrigation cannula will be written. So identify the gauge if they ask, and it will have two openings. The anterior opening is for the aspiration, and the side port will be connected to your the fluid. So this is a Simcoe cannula. Usually you use it, and all these are for the ECC procedures. Iris repositor for recurrent iris prolapse. So they can ask you when you will have a more iris prolapse. Suppose patient is on the benign prostate hypertrophy treatment, or patient is having high IOP intraoperatively, or you made the incision more posterior. In that case, iris prolapse, and you have to think of methods to remove or reduce the iris prolapse. Sinski hook and choppers. Sinski hook, you can see it is little blunt as compared to the chopper. You can dilate, and we use that in sometimes to remove the decimates, like in endothelial keratoplasty stripping and all. And compared to the chopper, which will be sharper. That's how we differentiate from the chopper. Kelly sponge is the trabecular punch where you use it. You can see here when you press, it will go and punch the scleral part, where you have to take a part of your block of your sclera as a Kelly sponge. This is Calazion scoop. Calazion scoop, as I told you, you have a clamp on the scoop. You saw the clamp, and this is the scoop which is used to remove the content. Coming to the lacrimal apparatus, this is the punctal dilator Castrovigio. The Castrovigio has got two ends with the dilating point. You can see the two ends you will have. One end will be sharper and very tip. The other one is nettleship punctum dilator, which will have only one end. This is nettleship punctum dilator, and that's the Bowman's probe. Bowman's probe will be available in various sizes. Here again, they will be asking about what are the uses of probe, what are the sizes will be used. Like 0, 0 is equivalent to 0.8, and usually in congenital block in children, NLD block, you do the probing. What is the age? Till 9 months, you do the massage, and after that, you do the probing. These are the common questions asked. And when you will go for the DCR, what are the other indications where you will do probing? Suppose you do a therapeutic probing, diagnostic probing. The enucleation spoon, it just goes by the name Wells enucleation spoon. Enucleation, we do it especially in intraocular tumors or any infection in blind eye. We do evisceration. We do for endophthalmitis chronic in patients and that. So here they again ask you in what case you should not do evisceration, especially in malignancy suspected patients, you avoid evisceration. And in enucleation, the other question is retinoblastomodal, you have to cut with the optic stump, the optic stump of more than 18 mm. As much as possible of optic nerve stump should be cut. So that the people who are interested in enucleation, they can ask them that. Epilation forceps, a common forceps you will be seeing in the OPD. You can see that flat ends is used to remove epilation. That means trichiatic lashes or patients having this dystichiasis. This bone punch is a Kerrison bone punch if you use in DCR. And again in DCR, if they go for the punch, they might ask you what the size and what are the indication where you will not do DCR contraindicated in rhinosporidias as a patient with atrophic rhinitis, malignancy. So these things you should know. The other few additional instruments, a freeze periosteal elevator will be looking like, but is more flatter than your lens spatula. It's a periosteal elevator. Enucleation scissor, you saw the spoon and this is the scissor. So this scissor is curved scissor. It is also available in straight also. Enucleation curved scissor, you go on the lateral side and cut the optic nerve because you have wide space there. That is why you go to the lateral side during enucleation. The ptosis clamp for Putterman's ptosis clamp, where we can do a torsimolar conjunctival excision. Vana scissor is a commonly used scissor. Again, this is very common instrument. They will be asking what are the uses of Vanas. You can use in your peripheral iridotomy to cut the iris, in anterior chamber to cut the vitreous, or even any tissue can be cut. When a sphincter, so a non-dilating pupil, you can use this Vana scissor for cutting. Stevens tenotomy scissors in SQUINT surgeries for the tenotomy to separate that soft tissue, they use Stevens scissors. Little ship punctum dilator. Indications for punctum dilator, again stenosis, punctal stenosis, acquired stenosis, or during the surgery when you want to put the probe and check, you do the punctal dilation. Wire vectors with irrigation. Tracheous periosteal elevator, it is right angled, you can see here. As compared to the previous one, flat one that was flat, this is right angle, tracheous elevator. Trifines, every person should know the trifine. We should not be very alien to the trifine. This is a corneal trifine. Various sizes are available. This stainless steel, this is the plastic coated. This is Hazen-Barron trifine, where you give pressure, and especially lamellar keratoplasties, increased pressure will make that lamellar keratoplasty easy. That's why this Hazen-Barron trifine. Here in corneal trifine, you should know what are the complications of keratoplasty when you will take the graft of same size, larger size. All these keratoplasty indicated questions and answers you should be familiar with them. Kimura spatula for corneal ulcer, if you want to take it scraping, you can use a Kimura spatula. You have to ask for other alternative where you can take it through the needle directly from that, or from the blade also you can take it. Vitrectomy cutters, very rarely they keep, but you should know what are the other vitrectomy cutters. You should 20 gauge, which is a larger opening. You have smaller opening micro vitrectomy cutters also 23 gauge 25. So it has got its own advantage, transconjunctival, sutureless, and less complications, less port related complications, sclerotomy port related complications. And when you are given vitrectomy forceps, look into the tip, whether the fine tips is it forceps or scissors. So accordingly, you can identify which type of forceps it is, in grasping forceps, or it is a scissor, it is cutting type. As you can see here, this scissors will have the blades, while the forceps will have the ends like this. And this is very common handle with blade, Bart Parker handle with blade we use for the skin incision, which is the 15 mm and 11 mm for the mucosa. So I think these are the common instruments we use. That brings us to the end of this instrument.
Thank you so much, ma'am.
Thank you.
Thank you for the visual aids. It really helped. Our next speaker is Dr. Shruti Nishant. She's a SQUINT specialist, pediatric ophthalmologist and neuro-ophthalmologist, and she's the executive director at MNI Hospital in Chennai. She has numerous publications to her name and has a special interest in visual rehabilitation in special children. It's very nice to have you, ma'am.
Can you hear me?
We can hear you, yes.
Okay, so thank you so much at the outset for having me here. Being a part of Kalpavriksha is a big honor. So I consider myself lucky to be a part of this wonderful group of students. So I'm just going to quickly take you through clinical evaluation of SQUINT. I know after a lot of an entire day of lectures, I think this is going to be the icing on the cake and it's going to be the so-called most tough part of pediatric ophthalmology. The word squint comes and everybody is like running in the other direction, but I think it's a big myth. It's like simple math. If math is something that's logical, so is squint. So I'm here to teach you to fall in love with squint evaluation and the basics of it. So what basically is squint? It is a misalignment of the visual axis with a failure of coordination between the both eyes. It may lead to diplopia, suppression, or amblyopia. And the cause of this can be all the way locally, right from the orbit to the muscles, to the nerves, blood vessels, or right up to the brainstem pathology. So anything along the pathway of the nerves can lead to a squint. Now, when it comes to type of strabismus, these are the three aspects they will ask you, and you should know. One is what is pseudostrabismus, latent strabismus or heterophoria, or manifest strabismus or heterotropia. So heterotropia is basically divided into comitant and incomitant. Comitant squints are basically squints that have the same angles in all gazes or all directions of gaze. And incomitant strabismus is the one where you have different angles at different deviation angles in different positions of gaze. Now there are two types. One is restrictive, where there is a problem with the muscle itself, which causes a fibrotic kind of a phenomenon which does not allow the muscle to move. The second is a paralytic, which involves a nerve and doesn't allow the muscle to move through paralytic process. Now, before we go on to it, why do we need to evaluate squint in a child? And this is a common question that they might ask. So the first and foremost thing is to establish a cause. So we really don't know what is causing the squint. So it could be a refractive error. It could be something like a media opacity or a cataract, or it could be a more ominous lesion like a retinal lesion that could be causing the squint. So we need to find out what is exactly causing the squint. Or is it just a squint in itself, or a primary squint like an intermittent exotropia? Second is to diagnose amblyopia or any form of visual deprivation that the child might have because of the squint. And the third is to plan for surgical correction by measuring the deviation. Now, when we come to squint evaluation, this is how we usually have to describe it: from history taking, visual acuity, refraction, clinical inspection, evaluation of sensory status, evaluation of motor state. We're going to deal with some special tests, and finally the anterior and posterior segment evaluation, which is a critical part of evaluation itself. Now, the ones that I've marked in red are the ones I'm going to be concentrating on for exam purpose. The rest are already probably going to be covered. It's the same for an adult and a child. There are going to be small differences when it comes to child, and we'll discuss that along the way. So before I go on to clinical inspection, I want to talk a little bit about history taking. So in history, we should first ask which is the eye that is squinting, because that gives us a clue as to possible visual deprivation in that eye. The second is whether it is an inward or an outward type of a squint. Why again? Because there are some squints that happen at some ages, which can be due to, like, infantile esotropias are more common in infantile age group, whereas intermittent exotropias are common in the slightly older age group. And that again brings me to when does it start? So same like that. In infancy, esotropias are more common, and in adulthood, slightly younger adults, the exotropias are more common. Was it a gradual or a sudden onset? A sudden onset can be more ominous of a paralytic or that kind of acute strabismus, incomitant strabismus rather than comitance. Whether it is constant or intermittent, again in intermittent exotropias, we see it more coming and going rather than staying constant. What are the precipitating factors? So many intermittent exotropias, you see them coming when the child is tired or sleepy, or when the child is not paying attention. So you look for precipitating factors like that, or you can look for trauma, convulsions, or any other neurological symptoms, or simply headache, nausea, vomiting, which can be a symptom of a squint. Look for diplopia, especially diplophotophobia in intermittent exotropia. Because of the intermittent exotropia, they end up having double vision. Whenever there is a diplopia, I ask them to look for uniocular or binocular, whether it is a horizontal or a vertical separation of images, which gaze is it worsen, whether it is worse for distance or near, and whether there is any diurnal variation. Now, these are 5 questions you have to ask for any patient with diplopia. So we have to take a note of this. Look for photophobia or any vision loss, any prior glasses or treatment history, family history, and medical history. So these are the things we look for. Now, moving on to clinical inspection. As the patient walks in, we need to take a note of how the patient walks in, whether they kind of have a head posture that we need to look out for. For example, these kind of face turns, chin lifts, head tilts, these have to be noted and very carefully. Look for facial asymmetry. You can see these kind of asymmetry. This is a superior oblique palsy, which is a congenital lesion which causes because of the constant head tilt and the chronic head tilt. You see that one side is compressed and the other side is expanded. This is a facial asymmetry where you have this kind of a congenitally displaced globes. And this is a third nerve palsy where you can see there is a ptosis, again cause for a facial asymmetry. Now, once you evaluate the facial asymmetry and the abnormal head posture, it's very common for people to say motor is evaluation first followed by sensory evaluation, but I beg to differ. It's always good to do the sensory evaluation first followed by the motor evaluation, because the minute you start cover or uncover, you're dissociating the eyes and that can lead to a false sensory evaluation result. So it's always good to do the sensory evaluation first followed by the motor evaluation. So what are the tests we do? We do stereopsis tests like the Lang's 2-pencil test. The quantitative tests are the random dot test, which is the gold standard. We have the TNO test, the Lang's stereo test, and we also have the Titmus fly test, the Polaroid test, the random dot, and the TNO. Here you can see this is the random dot test, where you can see there are 4 circles, and then we ask the child to point out which circle has a 3D effect, and it keeps going from all the way from 400 arc seconds all the way up to 40 to 20 arc seconds. So the lower the number, the better the stereopsis. So as they keep going through, the stereopsis number decreases, but the depth of stereopsis increases. Now, the second test that we do is the Worth 4-dot test. Now, here you can see it is done with a red-green glasses, which is a dissociating lens. And you can see the patient is asked to look at distance, and they have to say how many circles they see. So if they see 4, then that is fusion. Red for right, RR. So if they have to wear the red on the right side. So if they see 2 reds, then that's probably a sign of left suppression. If they see 3 greens, there is a possibility of a right suppression. And if they see 5, then that is a diplopia. And if it is red on the same side as the goggle, then it is uncrossed diplopia. And if red on the other side, if it is on the opposite side of the goggles side, then that is a cross diplopia. So usually exotropia, remember X. So X means crossed. So in exotropia, there is usually a crossed diplopia. That's how you can remember it. Now, evaluation of motor status, moving on, we have to measure the deviation and the ocular movements. So when you measure deviation, there are certain tests that you have to follow. The first is, of course, the Hirschberg's test, which is the primary test that we start off with. So when you have a normal reflex right in the center of the pupillary axis, then that is an orthophoria. But when you see it at the pupillary axis, it is equivalent to 15 degrees of squint, or roughly translates to 30 prism diopters of deviation. Again, between the pupillary margin and the limbus is about 30 degrees or 60 prism diopters. And between, at the limbus is a 45 degrees of squint or 90 prisms of correction, prism diopters. So it's actually twice the degrees. So the degrees are different and the prism diopters are different. It's important to keep them clear, the concepts clear in that. So here, if you see, you can see this is right in the center, and here you can see on the right side, the reflex is at the nasal margin of the pupillary axis. So you can see here, this patient probably has a 15 degrees of exotropia. And here again, you see the reflex falls at the limbus here on the right side. So this is a right exotropia, probably around 45 degrees, roughly around 90 prisms. So this is equivalent to this, what you see here. So next, after the Hirschberg is done, we have to do the cover, uncover, and the alternate cover tests. Now it is important to understand 2 concepts, and one's the Herring's law and the second is the Sherrington's law. Now the Herring's law basically states that the eyes are on the same line. So when you move one, the other one moves as well. So when the eyes move into one gaze direction, there is a simultaneous innervation that leads to the yoke muscles having an equal force. The Sherrington's law, as you all know, whenever there is an an increased force given to one muscle, it is accompanied by a reciprocal decrease in the innervation in the antagonist muscle. So it helps the yoke muscle move better. So these are the two laws that will be that are essential to know before you do a cover and an uncover alternate cover test. So this is another important question they might ask. What are the prerequisites for a cover test? So if you have to do a cover test, you need to have fixation. The child has to be able to fixate. So for a distance target, at least 660. For a near target, at least N36 or N. They need to be able to fixate. The second is the child has to be with refractive correction. They need to be wearing their glasses. The next is if there is any abnormal head posture, the head posture has to be corrected. And of course, you can use an occluder or a frosted occluder like a Spielman's occluder to test the eyes. Now, it is important to test both for distance and for near. This is something that can be commonly missed. And when you test for distance, it is important to test for all 6 gazes in horizontal and all 9 gazes in vertical squints. So let's do the first thing where here you can see this is an orthophoria. So when it is an orthophoria, you do not have a movement that is seen on cover and uncover. So you see when you uncover, there is no movement that you see. Now on the same, now let me go to an esotropia. When it comes to an esotropia, here you can see a movement that goes from in to out. Okay, so under the cover, the eye moves in out to in. Now here again, when they remove the cover, you can see on the other normal eye, there is no movement. When it comes to an exotropia, here you can see there is a left exotropia. When we cover the right eye, you cover the right eye, the left eye takes up fixation. So the minute the left eye moves, you know that there is a tropia and it is not a phoria. So this is the uncover test. So when you cover the eye, here again I'm showing you, when you cover, the left eye takes up fixation, the movement is out to in. So that means it is an exotropia, and this is what are the result of a cover test. Now when it comes to an uncover test, when you uncover, you have to look for the movement of the eye that had the squint. So when you uncover, the eye that was under cover was out, but it immediately takes up fixation. So when it takes up fixation, you know that the right eye is the stronger eye. Okay. So here again, you can see when you cover the weaker eye, it doesn't take up fixation. So what are the inferences that you get from a cover test? You can find out what is the type of deviation, whether there is an eccentric fixation, whether there's any amblyopia, pseudotosis, any nystagmus, and you can also measure the deviation. So as I was explaining the uncover test, when you have a left squint and you cover the right eye, the left eye takes up the fixation. So here there is a left exotropia. When we cover the right eye, which is the normal eye, the left eye, the squinting eye, takes up the fixation, which shows that there is a clear left exotropia. But what happens when you uncover? There are two things that can happen. When you uncover, one, the left eye, which was a squinting eye, may again go back into an exotropia, or it may continue to stay in fixation and the eye that was under the cover may go into exotropia. Now, when the eye that was squinting goes into exo again, it means that the right eye is dominant. And if the other eye, which was under covers, continues to be under exotropia, then it means it is equal dominance. So this is what is an uncover test result. So if it is an exophoria, you have to observe the undercover and you will see a movement under the cover. So in exophoria, there will be no tropia, but when undercover, you will be able to see a compensating movement. So this is an alternate cover test here. You can see when we alternately cover and uncover, you get a phoria plus the tropia component together. So this eye takes up fixation. When you cover alternately, this eye takes up fixation. So this is called the alternate cover test, which measures the tropia plus the phoria. Now, how do we measure the squint? The measurement of squint is done using the prism cover test. Now, the prisms are very simple. The apex has to face the deviation and the base has to face the opposite direction. So in esotropias, the prism has to be placed base out, and in exotropias, the prism has to be placed base in. Okay. In a comitant squint, it doesn't matter which eye you place this prism on, you will still be able to get measurements. So how do you perform the prism cover test? You place a prism of increasing strength in front of one eye and continue performing alternate cover test until the amplitude of refixation keeps on decreasing and the endpoint is reached when no movement is seen. But you do not stop there. You go and increase it until you find an opposite direction movement and then reduce it again to find the neutral value, and that will give you the final angle of deviation. That is the strength of the prism. Okay. So here you can see, we place it here. You can continue to see that there is a squint. So you keep using a higher prism. Again, there is a movement. Again, you see there is a movement. You continue to increase the strength of the prism. Now we have kept 50 prisms, and now to a certain extent it is reduced. So on and so forth. You keep increasing the power of the prism. The next test that you do is when children don't fixate, when the vision is very poor in one eye, you can do the modified Primsky's test. In uncooperative patients also it can be done. Here you keep the prism in front of the in front of the fixing eye, which is the better eye, and then you shine a torchlight and you see the pupillary reflex in the non-fixing eye, and thereby you'll be able to get a prism correction. Of course, you have to do the ocular motility test to see all the movements of the muscles. So this is just a quick chart that I refer to. If you see that in the temporal aspect, the recti muscles take over for elevation and depression, whereas on the medial aspect, the oblique muscles take over for elevation and depression. So in the medial aspect, the inferior oblique is responsible for elevation and superior oblique is responsible for depression. Whereas in the temporal side, the superior rectus is responsible for the elevation and the inferior rectus is responsible for the depression. So this is how you check your ocular movements. I think I am going to skip this because of time constraint. You should also keep a note on pseudostrabismus, which can be easily missed in mongoloid slants and in anti-mongoloid slants. And there is a concept called angle kappa, especially in hyperopia and in high hyperopia and in myopia. In hyperopia, you have a positive angle. The reflex moves nasally and causes a pseudo-exotropia. Whereas in myopia, there is more chances of negative angle kappa, where the reflex moves temporally and causes a pseudo-esotropia. It is important to see the anterior and posterior segment evaluation for completion. So you need to know what else is causing the squint. You can also look at the fundus for macular torsions, especially in inferior oblique overactions, which can give you a clue as to whether the inferior oblique is overacting or not. I think for want of time, I will be skipping this. So if you have a final diagnosis, you need to know whether it is which eye, whether it is comitant, incomitant, what type of tropia, what muscle is involved, whether there is a presence of amblyopia, what is the measurement of deviation, and what is the possible etiology behind the squint. These are the things that you should be able to tell at the end of the squint evaluation. So a good history, observation, and clinical testing is very important for a good strabismus evaluation. The most important is to have fun while you're at it. Thank you so much.
Thank you so much, Shruti. I think you should drink some water first.
Yeah.
That was a wonderful presentation. And just like you mentioned, I think all of us run a mile away when we see a squint patient and we just refer it immediately off to someone. But I think you've made it look very easy. And I'm sure everybody will find this newfound love for squint after your presentation. Thank you so much, Shruti, for being a part of it. Kalpa. Bye-bye.
I'd like to introduce our next speaker. Dr. Sumita Agarkar is the Deputy Director in Shankara Nethralaya in the Department of Pediatric Ophthalmology and Adult Strabismus. She has over 20 years of experience with many paper publications to her name, and she's also been a guest speaker at numerous symposia and CMEs. We welcome you, ma'am.
I'm thankful to Team Agrawal Eye Hospital for giving me this opportunity to talk on management of family. By definition, it is unilateral or bilateral reduction in visual acuity, which cannot be attributed to an organic cause. It is secondary to either an abnormal binocular interaction or visual deprivation during a sensitive period in the visual development. Clinically, it can be defined as an intraocular difference of 2 lines or more, or a best corrected visual acuity of 612 or less. Worldwide, 1 to 4% children are postulated or thought to have amblyopia. Of course, this is much higher in medically underserved populations. Most of our knowledge is derived from work of these two gentlemen who got physiology, David Hubel and Wiesel, who received the Nobel Prize for Medicine in 1981 for their work on discoveries concerning information processing in the visual system. And we owe a lot to these two gentlemen for providing most of the insights about the amblyopia. Now, what causes amblyopia? It is still not well understood, or we don't know everything about amblyopia. But what we know is that what are the factors which are responsible for normal visual development? They are three. One, adequate stimuli from each eye, corresponding retinal images, and intact visual pathway. Any of these things, if there is a disturbance in any of these inputs, it can lead to amblyopia. And amblyopia, which in turn leads to structural modifications of visual neuronal circuit and actual morphological changes in lateral geniculate nucleus and visual cortex. So, new research has proved that amblyopia is even if the visual acuity is less in one eye, is almost always a binocular problem and is basically a neural issue rather than an ophthalmic issue. Striate cortex or area V1 is the one which is most affected. In addition to poor vision, there is a loss of binocular vision. There is decrease in contrast sensitivity and motion processing, audiovisual processing, spatial audiovisual localization, and decreased vernier acuity. These higher order deficits not only affect the amblyopic eye, but also extend to the other eye. This is a summary of dysfunctions and deficits seen in amblyopia. What are the different types of amblyopia which we see? We basically, most common is strabismic amblyopia, followed by anisometropic or ametropic amblyopia, and deprivation amblyopia, which is relatively not that common. Now, strabismic amblyopia is due to lack of adequate stimulation to the fovea of the deviated eye. And this causes active inhibition of the retinocortical pathways originating from the deviated eyes. And these loss of binocular V1 connections lead to restructuring of ocular dominance column, which become thinner, and disparate images fail to fuse, leading to loss of binocular. In anisometropic amblyopia, it's the optical defocus or blur, which acts like a minor deprivation. Fine details are affected more. Hyperopic defocus is more likely to cause amblyopia than myopia. Unilateral high myopia, which is 8 diopters or more, usually behaves like a deprivation because the blur is so severe, and it also visual prognosis following therapy is also like deprivational amblyopia, little less than satisfactory. These are the most common causes of deprivation amblyopia, which are seen in children. And again, this is a severe form of amblyopia. Age and density of insult often determines the severity, and failure to reverse deprivation during the critical period leads to several structural and functional changes and often gives less than satisfactory responses to therapy. These patients usually present either a part of routine eye examination or failed school screening or covering one eye accidentally. Most often in children, trauma to the better eye is also one way of discovering amblyopia. And of course, during routine job application or college interviews, sometimes you will pick up. This is the part of workup of any amblyopic child. It is important to look for eye injury, any history of squinting or squint surgery, cataract surgery, any history of glasses. Not only that, but also family history of a first degree relative having amblyopia increases your risk of developing amblyopia. Similarly, history of prematurity also increases the risk of amblyopia. Visual acuity is the most important parameter to diagnose. Children are likely to perform with better with single optotype charts because of the crowding phenomenon. And we often forget to check near vision, but this is also one part of checking for the visual acuity in amblyopic children, because often near visual acuity improves faster compared to distance visual acuity. In Preverbal children, CSM method is a sensitive test, and unmaintained fixation almost always means poor vision and amblyopia. Photo screeners can be very useful as screening tools, and a 10 prism based down test again is a very useful test to look for fixation preference in very young children. So these are the charts which we use to check children. We also do sensory testing because achieving stereopsis is also one of our goals of therapy in amblyopia. So you need to establish baseline at the time of examination first. So this is a 4 prism base out test, which again shows a fixation preference. You can see in this video when you in the obviously larger and more anisometropic and slightly exotropic right eye versus the fixing or preferred left eye. So what happens when we put a prism in front of the right eye? As you can see, there is no fixational movement because of suppression scotoma in the right eye. While when we put the prism in front of the left eye, you can see a small flick convergence movement in the right, but no bidirectional refixational saccade. So this establishes a suppression scotoma in the right eye as well as monofixation, which is basically this child is fixing only with his left eye. Comprehensive ophthalmic evaluation is a part of amblyopia workup, and you must look for causes of deprivation, cover test to rule out strabismus, and ocular motility examination. Fundus evaluation is mandatory to rule out any kind of posterior segment anomalies, and last but not the least, a cycloplegic. How do we manage these children? Basically, these are our management strategies. Clear media opacities, give appropriate refractive correction, occlusion or penalization as required, and follow these children. So treating the cause for deprivation is important. So remove the causes of visual deprivation by doing appropriate surgical intervention as early as possible. However, this rule does not apply for pre-existing strabismus, where it is probably preferable to treat amblyopia first and then do the prescription of the glasses in itself is a part of amblyopia therapy. Pedic studies have proved that refractive adaptation alone improves vision in mild to moderate amblyopes. Almost 30% or 1/3 of children were no longer amblyopic after 6 weeks of prescribing glasses. Not only it improves the visual acuity, but it also reduces the burden of amblyopia and gives a better start to your occlusion therapy and ultimately better results. So this is Georges de Buffon, who is considered as father of amblyopia therapy, and he's a French natural historian who first laid down the principles or basics of therapy. So penalization is our mainstay, or occlusion or penalization is the mainstay of amblyopia therapy. It blocks the images or degrades the quality of images coming from dominant eye using either an optical mean like a patch or a pharmacological mean like an atropine drop. It enhances the neurological processing of visual input from them. At 1% atropine drops have been used as penalization thing very effectively. It causes visual blur and image degradation in the better eye. It is as effective as 2-hour patching in moderate amblyopia as found by ATS. Compliance is better than patching and less obtrusive, and most importantly, it allows some binocular interaction. This is a table looking at differences and between the two methods of achieving patching. But despite all that, occlusion still remains gold standard. There is a lot of divergent views on how much and how long to patch. ATS or amblyopia treatment study, which was done by pediatric eye disease investigator group, has rationalized and changed much of the way occlusion is prescribed. But ATS results need to careful interpretation before applying to clinical practice. Like ATS did not study deprivation amblyopia, and the conclusions of ATS do not apply for deprivational amblyopes or mixed mechanism amblyopes because those children were not included in that study. Let's look at 3 to 7-year-old children with moderate amblyopia, means visual acuity of 612 or worse, or 618 or worse. So ATS found that penalization and patching showed similar improvement over a period of 6 months. 2 hours versus 6 hours of daily patching showed similar improvement. And 1/4 of the successfully treated amblyopes can have recurrence within the first year. What happens if the patients had severe amblyopes? Both part-time and full-time patching showed similar improvement when they looked at 2 hours versus 6 hours. Now, did near activities help? Yes. Near activities did not make too much difference when treating moderate amblyopes with 2 hours of patching, but in children with severe amblyopia, near activities along with daily patching had an additive effect. What happened at older children? Again, here 2 to 6 hours of patching with near activities improved visual acuity, irrespective of whether amblyopia had been previously treated or not. Again, 2 hours of patching with near activities was as effective as weekend atropine with near activities. What happens if in looking at further older children, say 13 to 17-year-old? Again, patching helped in children with near activities. It improved visual acuity when amblyopia had not been previously treated, but failed therapy, with the history of failed amblyopia therapy earlier, these children are likely to benefit less with further patching if the patching had already been tried. What are the newer therapies? Behavioral treatments help. Practicing visual tasks repeatedly, which leads to permanent improvement and in the perception of the sensory task. It is a non-invasive, software-based, patient-specific interactive stimulation. It is available as a mobile app. Patient sits in front of the screen wearing the best optical correction and dominant eye is occluded. Response to visual perception task is displayed on the screen using a Gabor patch. And when you do the task repeatedly, it not only improves the visual acuity, but also improves other functions like contrast sensitivity or motion perception. Again, it has not proved completely superior to patching, but can help sometimes in older children or in amblyopes or in adult amblyopes. So, form perception learning can be several: fine form, contrast, noise, motion. So you can train eyes into these kind of visual tasks. Only problem with perceptual learning has been that it has not been studied in children as yet, and it has shown improvement in the visual tasks in which the eye is trained, but not really that much in everything else which they have not practiced. So it's still probably it is a work in progress, and probably more information needs to come out from this before we can really take it further, but it is available and you can use it as a software based. Video games, again, playing both action and non-action video games with better eye occluded works. It induces cortical plasticity and improves visual function. Video games induce a reduction in noise and an increase in sampling efficiency. Now, video games can be interactive like a virtual reality headset, or they can be simple games with one eye occluded. DigiRush, which is a dichoptic game and has been extensively studied, and did show as a part of ATS, did show improvement in the visual acuity. However, it was not shown superior. So video games are worth trying, but always caution parents about the addiction potential which these games have, like anything else and like any other. Now we are changing the focus from just vision to binocular vision, because one of the main criticisms of patching or occlusion has been that it does not improve stereopsis in a significant or a meaningful manner because of no binocular interaction. Now are focused on dichoptic training, which is where the contrast adjusted stimulus, which are slightly different, are presented to each eye, and brain is forced to integrate into one perception. So again here there are visual tasks where tasks can be completed only when and these tasks are presented dichoptically, and with the contrast of the image to the fellow eye attenuated, in order to encourage binocular combination of two inputs. Again, these stimuli are designed that person can perform the visual task only and only if he is using both the eyes. As you can see, red green glasses and a video game. So one eye sees the red game, the insect there, and another eye sees the other images. So child can play the game only and only if he's using with both the eyes. This is again something of experimental transcranial magnetic stimulation, where the magnetic field generated by a coil of wire placed on the head, which induces a weak electrical current and which stimulates the cortical areas. More information needs to be on this before we can recommend. Pharmacology. Yes, dopamine has been found to be reduced in the retina of the deprivational amblyopia. So increasing the level of dopamine in the retina may have a beneficial effect. That is the rationale behind pharmacotherapy. Levodopa in combination with carbidopa has been studied. Citicoline has been also tried, and with not very great results in either way. Most of these are used as adjunct, and it produces no benefit in children. Sometimes regression upon cessation is common, and sometimes can be used in an adjunctive therapy along with patching. Fluoxetine did not show really great results and showed no benefit in. This is also one therapy, as I said earlier, that perceptual training is not really studied in children, but AMPEL study, which has been conducted by University of Basel in younger children, we are likely to see some results coming out in future. So we need to watch out for this. Thank you for your attention.
Thank you so much for that extensive presentation, ma'am. And thanks for your presence and time as well. Oh, sorry. I didn't realize. Sorry, ma'am. Please continue.
I said you can stop sharing, I guess.
Oh, okay. All right. Okay, fine, ma'am. Then thanks a lot.
There were some case examples, but I don't think we have time for them.
Thank you. Thank you so much, ma'am.
Yeah.
I'll move on to our next speaker, Professor Rohit Saxena. He is a faculty at RP Center for Ophthalmic Sciences. His main interests are strabismus, pediatric ophthalmology and neuro-ophthalmology, and phacoemulsification. His academic achievements are extensive with more than 130 indexed publications, among others. Welcome, sir.
Thank you. Should I start my share?
Please go ahead, sir.
Yeah. So I have been given a rather difficult task to cover virtually entire strabismus in 15 minutes, which can be quite an ask. So I'll try and limit it to more flow charts. And by the way, is my screen visible?
Yes.
Okay, great. So I'm supposed to talk on entire horizontal and vertical strabismus, which, as I said, is virtually entire strabismology. So I'll try and give you some flow charts to keep information in place, so that as you keep reading, as you go along, you'll be able to place the information you acquire in appropriate boxes and learn more. So this will be more like a primer for you, but hopefully it'll leave you a little wanting to know more as you listen. So strabismus is essentially misalignment of the visual axis for one eye against the other. So that's the very basic definition, and really there are no classifications that can actually explain everything, and there are various types. So I'll just try and use the one which I just made up for this presentation. So we kind of divide it into horizontal and vertical, although a majority of strabismus you're going to have both, but grossly horizontal and grossly vertical I'll try and divide. So horizontal strabismus, you can have comitant and incomitant strabismus. Comitant strabismus essentially means that the deviation is equal in all gazes or all directions of gaze, and incomitant means that the deviation is different in different gazes. So the deviation is more in a particular gaze, say in levoversion, and it decreases or is absent in, say, dextroversion, as we'll see in certain cases of incomitant strabismus. The comitant strabismus would be an ESO or EXO or gross horizontal differentiation. Esotropias can be infantile accommodative. We run through the comitant ESOs and comitant EXOs in a bit. And the incomitant would be essentially paralytic and restrictive are the two gross kind of incomitant strabismus. Paralytic strabismus is due to an underaction or less working of one of the extraocular muscles, and restrictive is due to limitation of movement due to actual something preventing the eye from moving, and the extraocular muscle movement is the strength is essentially okay, but something is limiting the eyes from moving. Now, comitant strabismus would comitant esotropias would be accommodative and non-accommodative. The accommodative are ones in which the accommodational effort changes the amount of deviation. So why would that happen? All of us have an accommodation convergence effort. So something called accommodative convergence occurs in all, and it's a normal procedure. When we look from far distance to near, the amount of accommodation that we require or we use, look at the target in focus, will govern the amount of convergence that we are going to do. Now, if there is a problem in that, then you're going to have a problem in the amount of deviation or in the alignment that will be there. So it can be refractive, essentially meaning that there is a baseline refractive error. So if there is a baseline refractive error, the patient or the child is accommodating for distance, also along with accommodating for near. So if the fusional divergence, now again, and I'll be throwing a lot of terms like this to you, and I'll try and explain them as we go along. Fusional vergence is something that is keeping the eyes in all of us aligned. Our eyes are constantly under a stress of misalignment. So we know the orbits are outwardly placed. A lot of us, especially myopes, are exophoric. So if you do an alternate cover test on yourself or on your colleague, you'll see after a while that you will see the images jump, or the eye of your colleague coming in from out. So the phoria is broken. The phoria is controlled by our vergence mechanism, and fusional vergence is one of the strongest vergences that we normally have. Now, when the patient is accommodating for distance in accommodative with a high or a moderate hyperopia, then there is a tendency for the eye to go in because of the associated accommodative ESO or accommodative convergence, AC, accommodative convergence that the patient would or the child would have. The fusional vergence in all of us keeps it aligned. But however, if there is a high hyperopia, then the child may actually, the accommodative convergence may break and the fusion, and therefore there may be an esotropia. A non-refractive accommodative esotropia, the accommodative convergence is higher than what is normal. So normally we would converge by about 4 to 6 prism diopters for every diopter of accommodation, and in these children it may be much more, and in partially there may be a non-accommodative component to the accommodative. The non-accommodative essential infantile esotropia, among the most common esotropias we see, are ones in which there is no change because of accommodation, and there are a lot of non-accommodative esotropia. So you see an esotropia, they'll fall in one of these tables or this flow chart that you'll see. Exotropia, the most common would be an intermittent divergent strabismus, an IDS, or intermittent exotropia, which can break and become a constant exotropia. The most common types would be the basic type, where the distance and near deviation is same, convergence insufficiency type, where the near deviation is more than the distance deviation, the divergence excess type, where the distance deviation is more than the near deviation, and the simulated divergence excess. So if a child, you see that the deviation for distance is more than the deviation for near, it could be a true divergence excess or a simulated divergence excess. And why would there be a simulated divergence excess? Again, fusional vergences or a tenacious proximal fusion keeps the eyes better aligned for near or less divergent for near, and you have to actually break by doing a cover test or by occluding one eye for a little longer period of time to break fusion. So essentially we understand that variability in strabismus because of dynamic factors can be because of either the fusional vergence affecting the deviation or accommodative vergence affecting the deviation. So These are things we need to control. For accommodative esotropias, we need to do refraction and then measure them. Accommodative esotropias may require bifocals, and exotropias, again, we need to control one, give them good vision so that we can control the fusional versions, and of course may have to actually break to see whether they are true divergence excess or a simulated divergence excess. So these are comitant horizontal strabismus. We now move on to incomitant horizontal strabismus. The most common would be a lateral rectus palsy or a sixth nerve palsy. It could be acquired or congenital, most commonly acquired. Like I mentioned, they will increase in a particular gaze. That's why incomitance, the increase is in the gaze of the affected side. So if you see this patient, you can see there is a right esotropia. The esotropia increases in dextroversion. This eye is not going out. This eye moves in. For dextroversion, the amount of deviation has increased. In this case, there virtually is no deviation in levoversion. So this is an incomitant strabismus, a right lateral rectus paresis. So that's the most common incomitant horizontal strabismus that you will see. And the patient will present often with a face turn. So he's going to have a face turn to the right so that his eyes are aligned in levoversion. This is the most common horizontal incomitant strabismus. You can have a lot of causes. In children, it's often viral. In adults, it could be secondary to an ischemic mononeuropathy, secondary to systemic disorders like diabetes, hypertension. It can be a false localizing sign like in patients with raised ICT, where stretching of the sixth nerve would cause a sixth nerve underaction. And imaging is indicated in these patients if there is associated disc edema, there are associated neurological signs, there are multiple nerves that are involved, the symptoms increase or they are not improving within 3 months. So how will you manage? So you would generally wait for a while to allow them to recover. Between 4 to 6 months is our usual follow-up time. If it's a child, we may have to give occlusion therapy so that they do not develop an amblyopia. So nicely covered by Sumita just before. And how would you manage? So you would want to see how good is or how much action there is in the lateral rectus. So if the eye is able to move completely, you can do a recess resect procedure. Usually you'll do a supramaxillary amount of surgery. If there is less than normal movement of the lateral rectus, you may have to do transpositions, essentially provide force for abduction by the vertical recti so that you are able to augment the working of the lateral rectus. This is just to show you some of the cases. This is a sixth nerve palsy, post-orbitotomy. Note the good abduction here in this case. We did a large R&R procedure. You can see good alignment. It helps to get alignment as well as get good ocular motility. In this patient, you can see there was virtually no abduction. For this, we had to do a vertical rectus transposition also. So along with the medial rectus recession, we did a vertical rectus transposition. Half muscle with vertical recti were transmitted. Important, always a differential. A lot of children get unnecessarily investigated who were Duans but were thought to be sixth nerve. You look at this patient, small amount of ESO in primary gaze, but you see the amount of limitation of movement in levoversion, and in dextroversion, you can see the narrowing of the palpable fissure. It's important to note these things. Firstly, the difference between a restrictive and a paralytic strain, the most important being that the amount of deviation in primary gaze is much less compared to the limitation of movement. In a sixth nerve palsy, they almost would go hand in hand. So the severity of limitation of movement would reflect very clearly in the severity of esotropia in primary position. And the Duans will have a narrowing of the palpable fissure, a very important and common sign seen. So note palpable fissure narrowing, minimum deviation in primary gaze, and widening and abduction. So Duans is a kind of restrictive strabismus we talked about. There is retraction of the globe and narrowing on adduction, and there may associated be shoots. The eye may move up or down. So in this case, again, a right esoduans, you see the esotropia in right, you see the narrowing, and you see the severity of abduction deficit. This is another patient of right esoduans. How would you manage exoduans? We would preferably do lateral recti recessions. For exoduans where the lateral rectus is normal, again, you would like to do lateral recti recessions, but if there is very severe shoots, you may want to do lateral rectus with Y splits or even periosteal fixation. So Exoed ones usually would have very severe shoots, and they would usually require very large LR recessions. For ezoed ones, you would want to recess the medial rectus, but you don't want to recess the medial rectus excessively, because you may actually end up with adduction deficit. So sometimes you may have to recess both the medial and the lateral recti to overcome the shoots and the retraction along with correct primary gaze. Let's go to a bit on the vertical strabismus. Again, comitant vertical strabismus is essentially a pattern strabismus. Incomitant vertical strabismus would be a third and a fourth nerve palsy, and some of the other unusual conditions which we just kind of allude to without really going into details. Pattern strabismus, a very, very common feature seen with horizontal comitant strabismus. So a comitant ezo and comitant exo is very often going to have pattern strabismus. It's actually called a vertical incompetence in a horizontally comitant strabismus. A and V patterns the most common. So if it's an exotropia, your exotropia will be more in down gaze in an A pattern and more in up gaze in a V pattern. And similarly for esotropia and A esotropia, the eso will be more in up gaze and will be more in down gaze in a V esotropia. A pattern, a 10 prism difference is considered significant in A pattern, whereas for a V pattern, because we normally have a minimum amount of V, which helps us in convergence in down gaze, a difference of 15 prisms between up gaze and down gaze is considered significant. You would measure it for 25 degrees up gaze and 35 degrees down gaze. You can move the head up or down, and you can move the target up and down. So you can see the eye as it going out. So in this case, you can see the eye is moving out. So it's an exo with a V pattern. So a V exo. An alternate divergent squint with a V pattern, you can see the eyes less diverged down, more diverged up. In this case, always look for oblique overaction. You can see oblique overaction. Whenever you see 9 gazes, start with the central image, primary gaze, dextro, levo, and tertiary positions of gaze. So you can see a V pattern, you can see an inferior oblique overaction. In this case, you can see a V pattern, but you don't see significant oblique overaction. Here, when you're correcting the horizontal strabismus, you need to weaken the inferior obliques bilaterally. In this case, you'll be correcting the horizontal strabismus and you'll be shifting the horizontal recti to correct the V pattern. This is a case of A pattern. You can see superior oblique overactions here. In this case, you don't see any significant superior oblique overactions. Third nerve palsy would be the common paralytic vertical gaze, a vertical incomitant strabismus. So you can see ptosis in this patient. The eye is usually down and out. There is lack of adduction, right? Third nerve palsy, exotropic, lack of adduction, lack of elevation, lack of depression. So you can see ptosis, you can see pupil affected, you can see the superior rectus, the inferior rectus, the medial rectus affected, and also the inferior oblique. So along with that, you need to also check for intraocular muscles. Sphincter, pupil is dilated, look for near vision because the ciliary body also may be affected. Management, I'll quickly go through the key features of management. If there is aberrant innervation, you can operate actually the other eye and correct the exotropia along with the ptosis. Else you may have to do transposition procedures for third nerve. If you have a fourth nerve palsy, the other features besides, of course, a vertical strabismus would be in congenital. You'll see that the child will present with the head posture along with hypoplasia on one side of the face, showing that it's congenital. The patient may have torsion. A Parkes 3-step test will help to identify or to confirm a superior oblique palsy. You can see primary gaze, left hypertropia, the hypertropia increasing in dextroversion, also increasing in ipsilateral head tilt. So this is confirming a left superior oblique palsy. Always do a bilateral head tilt test in cases of trauma because there can be a bilateral superior oblique palsy. So both sides of the head tilt is showing you an increase in the vertical deviation. You will also have a much larger amount of excyclotorsion in a bilateral superior oblique palsy, a V pattern with a bilateral IO. This is how you look for excyclotorsion. You can see that normally it should be in the lower third of the disc, the fovea, but here you can see the fovea is displaced both sides, left more than right. So this is showing you excyclotorsion. For fourth nerve palsy, you can manage based on what you see. So if the inferior obliques are overacting, you would weaken the inferior oblique. If superior oblique is underacting, you may have to strengthen that. If there is a large vertical deviation in primary gaze, you may have to do both. Just a couple of slides on the other ones. Monocular elevation deficit is inability of the eye to move up. There are multiple reasons for that, but here you can see hypotropia increasing on up gaze, decreasing on down gaze. So this is a left monocular elevation deficit. Multiple types. You could have one because of an primary IR restriction, which can be due to trauma in the inferior rectus, a primary superior rectus palsy, which is the most common congenital monocular elevation deficit cause, and it can also be supranuclear gaze palsy, which you can confirm by just doing a Bell's or a Doll's. The eye will move up as a reflex eye movement, but it's not going to go up voluntarily. You need to decide the amount of deviation when you're managing monocular elevation deficit. You can do an inferior rectus recession, or you can do a NAPS procedure where you are going to transpose the horizontal recti, and again as a transposition procedure, augment the superior rectus. Finally, just to show you what a Brown's looks like. So they often may be aligned on primary gaze, but in the opposite gaze, like in this case, levo version, you can see the hypotropia and the eye is not going up and in. So a right Brown syndrome, limitation of elevation and adduction with divergence in up gaze. You have superior oblique overaction or inferior oblique not working, yet you have a V pattern or a VY pattern. So Brown's plus is when superior oblique is also overacting. So just to show you this, you can manage by a superior oblique lengthening procedure. Either you can put a silicon band, or you can do a chicken suture by suture lengthening, or you can do a split superior oblique lengthening procedure by just lengthening the muscle from the insertion or in between. So I just tried to cover up all the possible vertical and horizontal strabismus. I'm sure there is so much lacking, and I hope there will be a lot of questions in your mind. But like I said, I just gave you an overview just so that you can place all the information in appropriate boxes and add information as you go along. And thank you for the opportunity.
Thank you so much, sir. I mean, you managed to accomplish what you said was difficult. I guess the flow charts and the tables really helped condense all that. Thanks so much once again.
Thank you.
I'd like to welcome back Divya ma'am for the final topic of today and for this year's Kalpavriksha.
We should actually congratulate all the students who are still there to take up the last topic.
Yes.
This is again a Viva topic which you will be having in your exams of imaging, where you will be given pictures of ultrasound, CT, MRI, or OCT, UVM. So when you come to the imaging, you should be aware of the principles and what are the indications and what pathological aspects you have to look into the imaging system. So radiological, it could be divided as radiological, optical, and ultrasound. In radiological, you have X-rays, computerized tomography, MRI. Optical is optical coherence tomography. Ultrasound based are the ultrasound B scan and UVM. Now, after all, why should an ophthalmologist should learn to interpret the radiological images? How it's going to help? An ophthalmologist will be in a better position to anatomically see. At the same time, he has a functional knowledge, clinical knowledge, and what he is supposed to look for. And even if you send a patient for radiologist who is not often doing patients of orbit, so it will be like once in a while you will be doing an orbital case. But in your practice, if you are seeing patients regularly of the orbit, and you should be aware of the anatomical and pathological features you have to look for. So CT scan is the common investigation. It is faster and it is usually done with the commonly for axial and coronal planes for the orbital involvement. So X-ray transmission in CT scan varies a little bit from the MRI, and the principle also varies depending upon the attenuation of the X-rays, because in CT scan the X-rays are transmitted or attenuated. So if it is not transmitted, it's reduced, then it's basically the bone which gives you the hyper reflection, as you can see. Then ISO in water regions, and if it is air, it will be like the X-rays can totally pass. So it is divided into Hounsfield from +1000 to -1000. The different types of CTs available can get a high resolution spiral CT or a standard CT depending upon the indication and what specifically you need in that. Prerequisites which you write in the prescription for the patient are the slice thickness, imaging plane, whether you want exactly sagittal or coronal or axial, contrast enhancement required or not, and simultaneous brain screening if needed. If any other modifications which you want to look for the radiologist specifically should be mentioned in the requisition. And in the reading CT scan, you always look for the laterality, whether it is right side or on the left side, abnormality should be seen. Another specific which are given in the upper right hand hand will be the slice thickness, Hounsfield units, which are all radiologist specific. Coming to the MRI, MRI is not the X-rays, it is a different where the magnetic resonance, that means you create a magnetic field around the patient, especially when there are protons in the body, they get aligned with the magnetic field around it, and then you introduce the radio frequency, there is a change in the spin, then you switch off the radio frequency, the spin comes back down, so there is a relaxation of T1 and T2 where there is a time frame difference and there is a relaxation difference where the energy is exhibited. So this is what is captured by the system and you get the images. In T1 relaxation, it is the spin lattice relaxation where the energized nuclei, that is here the protons, that give energy to the environment and attain the equilibrium. T2 is in between the nuclei, that means spin relaxation time where the decrease in signal from the excited nuclei to the surrounding unexcited nuclei. So the T2 relaxation happens in the later period. Coming to the MRI evaluation, you can see this is the coronal section, this is the axial section. So this is a T1 weighted MRI, this is T2. So in T1, as you can see there previously, the vitreous is dark in color, and T2 it is white, that is bright in color. So the fluids will be brighter in T2 relaxation, while fluids are darker in T1 relaxation. The differentiation when to ask for CT or MRI depending upon the orbital disease. CT, especially in brain CT, you will ask for the acute infarct and hemorrhage, or in a bony trauma, like suppose you are expecting a blowout fracture or a fracture of the orbit with multiple fractures of the face, you go for the CT scan. Infections involving especially orbital infections, or you have to go. Calcified mass like retinoblastoma, any lesion with calcification, you will ask for the CT. Foreign body, these are the indication commonly. And the advantage is very quick and inexpensive and easy to perform. The patient need not stay for longer time inside the cabin. But the disadvantage is radiation exposure. Comparing to the MRI, the orbital nerve imaging, orbital apex, means the intracanalicular or orbital part of the optic nerve are well visualized in the MRI. Soft tissue, vascular, these components are seen better in the MRI. Intracranial extension of any tumors, it is also good. But the disadvantages you cannot use in patients with metallic implants like cochlear implants or intraocular foreign body. And it can produce claustrophobia. Patients have to lie down for longer period. If they are having that disturbance, then again it is not indicated. So in acute hemorrhages, usually they go for the CT scan. And there is no radiation, so that is advantage. MRI has got less radiation exposure, or actually nil radiation, because here there is only magnetic field which is being introduced compared to the CT scan where you introduce radiation. So that is a difference. And now here you can see the pictures of the MRI brain and the CT scan. You can see the difference, how it is. The bone is clearly seen in the CT scan, while the soft tissue is visible in the MRI. In these planes, how you usually look for in the orbit, you have axial plane. This axial plane from the upper part, if you see the eyeball, it will be looking like this. This is axial. Then this is a coronal section across in the front. Sagittal is cut on the sagittal axis, where you see the globe with the optic nerve on the orbital apex. This is sagittal. So especially when you have the blowout fractures, you go for the sagittal section and coronal section. If you want to look for the orbital apex and orbital canal, this is the canalicular part of the cavernous sinus, you go and look for the this axial section. If you want to see for the proptosis, you draw a line with the interzygomatic line in the CT, or look for the globe position. So half of it will be in the side, but as you can see here, the entire globe is outside, so there is a proptosis. This Hillel-Trockell method of evaluation of the proptosis. Interorbital line is the other evaluation where this distance between the medial orbit is measured. So in tumors or any mass lesion, we classify into intraconal or extraconal depending upon the cone, muscle cone. So you see this, these are muscle reflection. So if it is inside this cone, it's called intraconal. Anything outside this cone is called extraconal. So the mass also, specific masses could be defined as intraconal, extraconal depending upon the position inside the orbit. You always measure the orbital dimension. Suppose if it is a large tumor, it can produce bony fossa formation where this bone is eroded. This orbital distance itself will be enlarged. So the interorbital line measurement will be increased. In evaluation from down to up, you have to look for certain structures where whether it is normal or abnormal. So if you see in the superior part, you will see the lacrimal gland, superior ophthalmic vein, then you have the muscle, superior rectus and superior oblique muscle. Then you come to the middle plane, mid-axial plane, where all the structures are visible, including your muscles, extraocular muscles, optic nerve, entire globe with your optic canal and superior orbital fissure, sphenoidal sinus. Coming down, you will be seeing the nasolacrimal duct, maxillary antrum, and the lower lid soft tissues, the inferior orbital fissure, the nasal septum. So the mid-axial scan gives you the majority of your finding in the orbit, especially the orbital apex, superior orbital fissure, optic nerve, and your entire globe with extraocular muscles with the lacrimal gland. There are two windows, bony and the soft tissue window. The bony window, you will see majority of bone reflection, where you see that hyper reflected bone structure. Soft tissue, the soft tissue is predominant. So this is a patient lower fracture. Both the soft tissue and bony window, you can take it and identify. And if you want to specifically look for any vascular lesions, you inject contrast. This is the contrast enhancement seen here in a mass lesion, which is infiltrating here, where there is a contrast enhancement. This before enhancement, with the contrast, you can see actually there is extensive vasculature inside the mass lesion, and it is producing proptosis and pushing the globe to the outward side. So if you see this, you take up a differential, it's well localized inside or it is capsulated. What is the heterogeneity? Because it looks heterogeneous inside, but it inside the capsule. So probability of the other vascular lesions like cavernous hemangioma or vascular mass should be taken. So here you can see this is a vascular lesion with the contrast, it is enhancing and it is going near the cavernous sinus. So it is connected with cavernous sinus thrombosis, causing the enlargement of the cavernous sinus. The mass lesion here in the orbit, where you can see isodense is pushing the globe down and out, but it is also having calcification spots. So this patient might be having any lesion with calcification of orbital varices. Contrast might help him, where it will produce increased enhancement. Here a patient with thyroid ophthalmopathy, thyroid we use muscle thickness evaluation, where he is having active disease. So you should be having muscle thickness. Here you can see that enlarged thickening of the muscle. Belly, so spared, the tendon is spared, the belly is involved, the champagne bottle appearance. And this muscles in the coronal section, you can see medial rectus. So it is going in this order. The medial rectus is initial, then late inferior rectus is involved. So the patient will be having acute symptoms like pain, redness, restriction of movement, squint, double vision, everything. So this is a comparison. The close differential with thyroid ophthalmopathy is the myositis. So here if you see the myositis, the entire muscle is thickened. Here you see the shape of the muscle. So this shape is often seen in the thyroid, where this tendon is spared, the tendon is involved in myositis. You see this patient also will have pain and redness, restriction of movement. So you have to look for the differentiation in the imaging. This is a patient with proptosis. You can see there is a chronic protrusion of the left eye and the limitation of movement on CT. You can see there is enlargement of the lacrimal gland here. So whenever you see lacrimal gland, you always look for any other associations like a fossa formation, infiltration. Accordingly, you divide into malignancy or not. In patients, whenever you are going for any orbitotomy, where you have planned the incision depending upon the position. Suppose the lesion is more in the anterior orbit, so you go for anterior incision. If it is the medial orbit, you have to go transcaruncular or in the medial canthal. In the lateral aspect, you have to go for modified stellar incision. So you plan your orbitotomy incision after doing the imaging. This is a patient with your painful with red eye. You can see that chemosis there. There is mechanical ptosis, tenderness present. So on examination, she had a large lacrimal gland. So it's an infection, it's dacryoadenitis. You can also have tumors. See, this is a tumor of the lacrimal gland, which is pushing the globe medially down, and there is a mild fossa formation. So if it is painless and non-infiltrative, then it could be a pleomorphic adenoma. So infiltrative or lymphoid combination can be there with no bony changes in lacrimal glands. Pleomorphic adenoma can have a smooth formation, well-defined fossa forming. Malignancies can have irregular surface, calcification, erosion, and can cross the midline. This is a patient with medial canthus mass, which is clinically looks like a dermite. So if you do a CT scan to look for intracranial extension inside the orbit, it is more superficial, anterior orbit only. Fat suppression shows it is going to be a dermite. Biopsy also came out as dermite. Same female with the superior orbital superinasal mass lesion. It is like a homogeneous lesion pushing the eyeball down and out. In the CT scan, you can see, and this turned out to be a schwannoma. It's a non-axial proptosis. So this is where you accordingly plan your orbitotomy. So this patient will have direct access to the swelling if you make in this superior aspect, anterior orbitotomy for it. Comparing the soft tissue evaluation. This is an MR with CT scan evaluation. See, this is a CT scan where you cannot clearly delineate how extensive is the lesion, infiltrative lesion. However, in MR scan, you can see that infiltrative lesion is extensive, involving the wider region as compared to the CT scan. That's why if you want a soft tissue lesion, it's better to do an MRI. Coming to the intraocular calcification, this is the patient with drusen in the optic nerve head. You can clinically see in the indirect also. If you see or the ITD, you will see the blurred margin of the optic disc. Here you can confirm it with the calcification spot on the optic nerve. Other calcified lesions, like especially retinoblastoma, well seen with calcification, and which is missed in which may not be seen in MRI. And but nowadays we do MRI, especially in retinoblastoma, because no radiation exposure. But times we have to do because there could be a trilateral retinoblastoma where pineal blastoma can also be there. So this is a vascular lesion where you have to do a contrast. So you can give the contrast. Actually, you can see small spaces, vascular spaces inside the mass lesion. It's actually a cavernous hemangioma, which is called florid vasculature with spaces inside. Well seen in MRA angiogram. Here you see a patient with neurofibromatosis who is having this ptosis, that is with the thickening of the upper lid, neurofibromatosis plexiform type. You can see when you palpate this patient, you will have this bag of worms appearance. Actually, in the MRI, you can see this plexiform neurofibroma in the imaging typically. In intraorbital tumors also, the MRI plays a major role where you have to look for the infiltration of the choroid, sclera, extraocular, orbital involvement, optic nerve involvement. So here is a patient with choroidal melanoma with the T1, which is hyper, and T2, it is hypo. It is a clear collared mushroom-shaped mass lesion. And the previous one was the trilateral retinoblastoma I was telling you. Retinoblastoma with the epineal gland mass. So other congenital anomalies like a short socket or dysplasia of the sphenoid, like this dysplasia of the sphenoid, or orbital socket itself is small because of microphthalmus, can be made out by CT. And you can also see the optic nerve glioma here, or optic nerve meningioma in evaluation. Blood fracture is important CT scan, which can be kept in exam. We always look for the coronal section and see this teardrop sign or trapdoor sign. There's a break in the, or there is a discontinuity of the floor of the orbit. There is a soft tissue, especially the inferior rectus and the facial planes, fat are entering into the maxillary antrum. Here you can see the air entering into the orbit, causing the orbital emphysema. So clinically, the patient might have crepitus. And you can see this trapdoor pattern. There is hemosinus in the maxillary antrum. There is sinus here. The sinus also filled with blood. So this patient should be insisted that you should not blow the nose. Otherwise, we'll have more air entering into the orbit, producing pressure effect on the optic nerve. So now these are the common MRI CT scans you will be shown. Other things as a theory part, as a time code and a gold standard, you should know how X-rays are being used. Like you have the Calvel Waters view and all being done for paranasal sinus and orbit. And nowadays we don't often use it because it has been replaced widely by the CT scan, which is easily available. And usually they used to do for foreign body. This is a limbal ring method where they place a limbal ring in the limbus and identify how anterior or posterior is a foreign body in the olden days. Other investigation is the DCG we use for the duct, nasolacrimal duct, injecting the dye in the canaliculi and see how much is where is a block. And this is another investigation we can do to identify the level of duct blockage. So you can see here the duct, it is patent, in the other side it is blocked, so it's not, dye is not entering. Digital subtraction imaging, which is not often done, but for functional evaluation, you can in the patients with the functional watering epiphora to identify, you can do a scintigraphy. Coming to the ultrasound, which is commonly done in your OPD, everyone should know it is around 10 megahertz, megahertz, which is used for the ultrasound probe. And here is a piezoelectric crystal which moves in direction. We keep it on the eyeball. There are various scans available, axial, transverse, and longitudinal, depending upon how you keep your probe, the direction, perpendicular in case of longitudinal or parallel in case of the transverse. So you identify the structures in the ultrasound. So here, because it is an ultrasound, which is a sound-based instrument device, you see the sound going inside and coming out as the echo delay. So echo delay is the time delay which is detected as the evaluation of the structures. Like you can see normal is lens, vitreous, retina, vitreous is anechoic. Then you have the shadow, which is the optic nerve. The corresponding A scans will be shown as spikes. You get high spikes in retina and sclera, and then in the posterior segment, anteriorly you will get in the lens and the cornea. So UBM is the higher frequency, that is 30 megahertz and 50 megahertz are available. It's ultrasound biomicroscopy, which gives you better resolution. When you go for the higher frequency, the depth of penetration decreases. So you will see more of an anterior segment only in UBM. The key points you have to know in theoretical aspect is the wavelength of the machine, reflectivity, gain, how much you keep. If you want to see very subtle structures, you have to increase the gain. Very thick structures, you have to reduce and see whether it is persistent. Then angle of incidence, velocity, especially in silicon oil filled dye, velocity reduces, normal light is high. What are the types of methods of evaluation? I told you axial, transverse, and longitudinal, and probes. This is an axial image on the optic nerve to see the lesion if it is in the posterior segment, and you want to see the extent of the lesion, you go for the transverse, and you want to measure how much radially it is involved, longitudinally it is involved, you can use the longitudinal section. So optic nerve is well seen in the axial. Coming to some of the pictures you see in routinely, it is a posterior vitreous detachment, is a thin membrane, senior is a vitreous opacity. So whenever you describe, you have to measure it, say it as a mild to moderate opacity, say mid vitreous with a thin membrane. You should look for the movement of the membrane, whether it is attached to the disc or not. Retina is always attached to the optic disc, and it persists even if you reduce the gain up to 40 decibels. So reduce the gain and see. Undulating movements will be seen in fresh retinal detachment. If it is a partial PVD, it will be attached after. If it's a complete PVD, it will be detached from the optic nerve. So you can also look for the asteroid hyalosis, a thick asteroid hyalosis with PVD and a very subtle nevus. Here you can see the subbiloid bleed here. So this is vitreous and you have the bleed here. So you see the difference between the hemorrhage, which is more heterogeneous as compared to the normal vitreous. This is a mass lesion. Again, it's a cholested pattern, typical of a choroidal melanoma, the exudative body here. So in choroidal melanoma, you should look for the lesion. Inside the lesion, how much is the reflectivity? You will get a low to moderate type of reflection inside, unlike your choroidal hemangioma, which will show high reflection. And you always look for the kappa, angle kappa sign, where there's attenuation of the reflection inside the mass lesion. This is angle kappa. From immediate, there will be high reflection, slowly it will drop down. So this is called angle kappa, low, medium, interreflective. Acoustic hollowing inside the lesion. Orbital shadowing will be there, and choroidal excavation. These are all seen here in this image. You can see that choroidal excavation in the choroidal melanoma. This is an hemangioma, which I showed you previously was a melanoma. Here you see there is an increased reflection inside the mass. So this is a high spikes called dancing spikes, which are seen in the choroidal hemangioma. It can have exudative RD both in hemangioma and melanoma. The orbital structures can be seen even with ultrasound. You can see the orbital structures like he is a muscle, and the fat will be appearing white in the ultrasound. This is optic disc drusen we saw in CT. Again, drusen can be seen in optic disc. This is a calcified spot. Staphyloma, again, many of them they will be showing in B scan with staphyloma, high myope, where more than 20 diopter and all, minus 18, minus 15. We can see the posterior staphyloma here. So that can also be kept as your spot. Fluid in the subtenon space seen in the posterior scleritis, inflammatory nodule overlying it. You have to see, especially patients having painful red eye with movement on eye. So you have to look for this tenon sign. So this T sign which is seen in the posterior part of your tenon, this is the tenon fluid, especially in the posterior scleritis, it's called the T sign. This is the classic sign of the cysticercosis, orbital cysticercosis. You see the hyperreflective spot inside this hypoechoic region. So this is the cysticercosis pollex, and this is a cyst. So this patient might be having some cysticercosis diagnosed. This is a orbital hemangioma, which is showing high reflection. So you can see here is ultrasound of the astral hyalosis. Previously I showed this is a reflection or hyperreflective. The reflection actually you can see it is very high. So it is unlike your hemorrhage or the PVD or vitreous debris which I showed you. So this is a patient with a retinal detachment. You can see the thick membrane. So how see the movement and how it is attached to the optic nerve. And there is a there is one PVD with vitreous debris. So this is a retinal detachment. So this persists, this reflection persists even if you reduce the gain. So this is the mass lesion. So obviously this I have shown you 2-3 pictures. The melanoma with exudative retinal detachment. You can see this retina is elevated below. Coming to the optical imaging is OCT is a commonly used one which has got better resolution of the anterior segment. Other one is a UBM which has got lesser resolution, but there are some advantages where you will use UBM and where OCT may not be used. So OCT depends upon the constructive interference, the coherent waves, the trough and the valley, the valley and the peak will be together. It's called coherence. So this works with the principles, Mickelson's interferometry. We're not going into detail of that. The two types, time domain and Fourier domain. You have to remember this time domain doesn't use Fourier transformation. Fourier domain does. Reference arm moves in time domain, do not move in Fourier. And the resolution. The better resolution is given by the Fourier domain. Fourier domain is equivalent to the spectral domain. Both are equal, both are same only. So the higher resolution is obtained by the Fourier domain. So you can see here the OCT of the posterior mass lesion. You can see the retinal fluid here. There is elevation in the choroidal. So you can see the mass lesion in the choroidal level. So metastasis, and here it is the mass lesion. It can be used in the anterior segment. OCT can be used in the ocular surface squamous neoplasia. You can see the snout sign here. You can see the increased thickness of the epithelium. There is a mass lesion, hyperreflective epithelium. So you can use it for various anterior segment. You can see for decimal stripping or incision of the cataract, keratoconus, acute hydrops, angle recession, and IOL position or lens thickness. Everything you can do anteriorly. It's a non-contact method. So routinely you can use it for other evaluation of the anterior segment. IOL position for tilt and association with your iris structures. And here 3 pictures you can see. The first one is the UBM, second is the anterior segment OCT. And UBM advantages, you can see the ciliary body. Here you cannot see it. So that is the disadvantage of the anterior segment OCT. Second disadvantage is the OCT is light-based instrument. So the light will not penetrate your iris pigment. So it will stop it. That's why in UBM, you can still see the posterior part of your lens, posterior, anterior part of your vitreous, scleral spur, everything is seen in the UBM, which is not seen in the OCT. The third one is the pentacam, which is based on the Schlieffen imaging. The last one is the UBM. UBM, as you said, the B scan has got 10 megahertz. UBM has got a higher frequency, but penetration is less, 5 mm, gives a resolution of 50 microns. Coupling fluid, so it is a contact method. Normally, you see the angle, iris structure, ciliary body, pars plana, plicata, which is highly vascular and plicated. Iris configuration can be visualized. Here is a bar. This is a pars, this peripheral anterior synechiae. Can be seen, and the IOL position can be visualized. Narrow angles can be seen, and you can actually see the position of the iris and the IOL in patients. In AC IOLs or different types of IOLs, post YAG PA, you can see the PA being opened. In post trabeculectomy cases or a patient with a stent, that is like glaucoma valve, you can visualize these structures. In angle recession or in ciliocoroidal changes, there is ciliocoroidal detachment due to trauma where the patient is having hypotonia also, the UVM comes into play, which may not be evaluated by an OCT. Post-surgery in cataract, very limited because the immediate post-op we don't do it. OCT is the best option. Foreign body localization you can do here. You can see the foreign body, and OCT also picks up the foreign body. And I already showed you that ciliary body mass or ciliary body cyst can be seen. Here is a mass lesion solid, and here it is a cyst. Both can be visualized by UVM. UVM is a contact method, so do not do it in the open globe injury or immediate post-operative period. Only indicated wherever necessary you have to go for it. And difficult to perform in uncooperative patient. Obviously, coupling fluid is needed and its contact, so it's difficult in children. And resolution is less as compared to the anti-segment OCT. So coming overall, we have covered the imaging. Most of it is like radiological, optical, and this ultrasound are the common imagings we do in ophthalmology. I think that's the end of the session.
Thank you, Divya ma'am. I think we've troubled you with enough sessions for today. You had a lot of talks. I think you definitely need a rest on a Saturday night.
Actually, the imaging
just to talk a little bit, whatever I can cover, I try to cover.
It was excellent, ma'am. It was excellent, especially the imaging and the instruments. It's very practical for students. Thank you so much, ma'am, for being with us. And I think that brings us to the end of the 3-day Kalpa program, which we had. We had wonderful speakers in all the 3 sessions. And we hope to meet up for in-person session next year, hopefully. And I'd like to thank the IT team, specifically Mr. Ravi, Mari, and Sujata for seamless functioning of the entire program. Thank you so much. Soundry ma'am,
Dr. Vaishnavi, actually you put up the program together and it is a big success. Thank you so much.
Thank you so much. Thanks, everyone. Thank you, ma'am. Good night.
Thank you.